Good evening, or good evening. I'm used to doing these at night. Good morning, everyone. Welcome to our Woo You presentation. Tonight, we get to hear from the one and only Dr. Mitch Eibach, and he's going to be talking on open or closed, how we treat glaucoma. I'll be your host tonight. My name is Dr. Ariel Sorenzi. So for CE, please be sure to stay on for a minimum of 50 minutes per hour of credit. This will be worth 2 hours of credit for this particular presentation, and then Dr. Steens will be another 2 hours after this. We'll have a QR code at the end of the presentation, but we'll also have a survey that will be sent out to everyone via email if you happen to miss that QR code. But with that QR code, you can just open your OE Tracker app and scan that for instant credit. For Q&A and handouts, you can find that on the right-hand side of the page. So be sure to ask some of your questions in the Q&A over there, and we will get to those at the end of Dr. Eibach's presentation. So it's my pleasure to introduce Dr. Eibach. He is a residency-trained optometrist at Vance Thomas Vision in Sioux Falls. Dr. Eibach attended the Pacific University College of Optometry, where he graduated summa cum laude, and completed his residency training at Minnesota Eye Consultants with a concentration on cornea, refractive surgery, external disease, and glaucoma. In September of 2014, he joined Vance Thompson Vision to focus on advanced anterior segment surgery care and pathology. He is a fellow of the American Academy of Optometry, Intrepid Eye Society member, and a board member of the International Keratoconus Academy, a member of the AOA, Optometric Glaucoma Society, and the South Dakota Optometric Society. Dr. Eibach is the residency coordinator at Vance Thompson Vision and is also an adjunct clinical faculty for ICO and the Northeastern State University of Oklahoma College of Optometry. So we are so excited to hear from you today on all things glaucoma. Here are his financial disclosures, all of which have been mitigated. So I will have you take it from here.
Awesome. Thanks, Dr. Sorenzi. I will always follow her, except on this one. I'm going to say good morning rather than good evening. Hopefully you guys are still in your jammies on the West Coast. You're enjoying some coffee. In the Midwest here, we're kind of mid-morning. And on the East Coast, you guys have already put in a half day. But we're ready to talk glaucoma. We have 100 minutes here to discuss glaucoma. And this first 2 hours is really going to hinge on what's the angle anatomy. Do we have the natural anatomical drain of the eye open or closed? And then what type of glaucoma are we gearing up to treat? I'm Mitch Eibach. I'm an optometrist with Vance Thompson Vision in Sioux Falls, South Dakota. And somehow I'm going to make that bio shorter. I actually had a fun idea to just start with the 1998 Bulls intro song when they were winning championships with Michael Jordan, but we haven't figured it out on the platform yet. And so my day is chocked full of cataracts, cornea, refractive surgery, dry eye, and glaucoma. I maintain a large continuing care glaucoma practice. And so we're going to start with 1,000-foot view. First, why? Why do we treat glaucoma? Well, simply to preserve visual acuity and visual field. There's been many consumer surveys where they ask consumers, what is your most precious sense? Or said a different way, what is the sense you are most fearful of losing? And over again, it's vision. And then second, we treat glaucoma to preserve quality of life. There's a 2022 branch of the Los Angeles Latino Eye Study where they used vision-related quality of life scores. These are people with glaucoma, and people with glaucoma who had visual field loss had worse scores. Not surprisingly, patients who had visual field loss in both eyes had even worse scores. And then patients who have open angle glaucoma and angle closure glaucoma who have visual field loss had worse psychological or mental health as well, one of the big ones being depression. And so in glaucoma, we have all these different tools. We have a lot of tools, tests, diagnostics to diagnose glaucoma. Many of them are shown here. We have IOP, family history, corneal thickness, hysteresis, what the optic nerve looks like. But treatment in glaucoma is unilateral. It's just one thing. We try to lower the interocular pressure. After or as you are making the diagnosis of glaucoma, one of the big determining factors of how we are going to treat this patient is gonioscopy. Is this angle open or closed? And so gonioscopy, being able to assess the angle, is going to really determine how we are going to try to treat our patient. And so this is the deciding factor. On the left, you can see this open angle. You can see the ciliary body. We have scleral spur, trabecular meshwork here, pretty flat angle at approach. And then on the right, we have a closed angle. There's maybe one or two spots. We can see Schwalbe's line. Maybe if you use your imagination on Sunday morning, you can see posterior trabecular meshwork. But in both scenarios, open angle or closed angle glaucoma, we're trying to lower the eye pressure, but we're treating these patients very differently. And so we're going to start with the patient on the left, the open angle glaucoma patient. And so we understand the why we treat glaucoma, but now how do we treat open angle glaucoma? I said it revolves around lowering the IOP. When I diagnose a patient with open angle glaucoma, we're going to make our treatment plan. I'll say to the patient, for treatment in glaucoma, it all revolves around lowering the eye pressure. There's 4 mainstays in lowering IOP. We have topical glaucoma drops, we have laser procedures or laser trabeculoplasty, we have drug delivery devices, and then we have glaucoma surgeries. And in glaucoma surgeries, there's this very big spectrum of minimally invasive glaucoma surgeries that prioritize safety, still are efficacious, but take a safer approach. And then we have big incisional glaucoma surgeries like tubes and trabs. And so treatment is really just IOP lowering. There are studies that are being done around nutraceuticals like ginkgo biloba and nicotinamide. Maybe it's blood flow theories, but for now, in treatment in glaucoma in the US, we are lowering IOP. And so let's start with an update on topical glaucoma drops. Drops are still the most common first-line treatment in the US for open angle glaucoma. And I think this table is a really nice overview slide. It shows us our most commonly prescribed topical glaucoma drops in the US. With glaucoma drops, we're really targeting 3 main mechanisms of action. And so we can try to increase aqueous outflow through the trabecular meshwork or conventional outflow pathway. We can try to increase aqueous outflow through a secondary pathway, the uveoscleral outflow pathway, or we can try to decrease aqueous production. And you can see where these drops fit here. And I think to better understand the treatment of glaucoma, it's really nice to have a refresher on the production and drainage of aqueous inside of the eye. And so aqueous or pressure is made in the posterior segment at the level of the ciliary body and ciliary body epithelium. Aqueous has to travel around the lens through the pupil, and then it enters into one of 2 aqueous outflow pathways. First, the trabecular meshwork or conventional outflow pathway. This makes up 50 to 90% of our aqueous outflow. Fluid has to get through the trabecular meshwork, this smooth muscle, almost like a sponge. It's pumping, has to get into Schlemm's canal, get to the aqueous collector channels, and then branches off into the aqueous veins and episcleral veins. The conventional outflow pathway, this is where our Rho kinase inhibitors work. And so notarsidol and notarsidol plus latanoprost, pilocarpine, one of our legendary glaucoma drops, has its primary mechanism of action on the trabecular meshwork. Latanoprostine bunad has a secondary mechanism at the level of the TM, and maybe vitmatoprost does as well. And if fluid doesn't go through the trabecular meshwork outflow pathway, the other 10 to 50% goes through the uveoscleral outflow pathway. This is a potential space. Ultimately, fluid exits kind of the eye space in between the choroid and the sclera. And this is our prostaglandins. So our prost medications, you can see those down on the bottom left. And then on the right, we have our drops that are trying to turn down aqueous production. So aqueous suppressants as well as our combination medications. And so in the US, why are prostaglandin analogs first line. This is most commonly, we're going to prescribe a prostaglandin or a prostaglandin plus urokinase inhibitor first. Why is that? Well, first, it's the most efficacious drop class. If I'm prescribing a prostaglandin analog, I'm hoping to get a 25 to 33% reduction in IOP. Second, these are once daily dosed drops. Unfortunately, topical glaucoma drop compliance in the US is poor. Patients don't love taking drops. And so if we can use it one time per day, there's multiple studies that say patients are more compliant with one bottle or one drop per day than they are with 2, 3, 4, etc. Second, prostaglandins have minimal systemic side effects. We all know about the ocular adverse events with prostaglandin analogs. We can have periorbitopathy, or this kind of hollowing out, blackening out around the eye, eyelash growth. Our females sometimes love that. Our gentlemen usually don't. And then we can have iris pigmentation changes as well, but minimal systemic side effects. And then finally, uveoscleral outflow slows at night. There's studies by Arthur Sitt at Mayo. There's others who have done this that have shown that when we are in a supine lying down position, our uveoscleral outflow slows. And so maybe this at least partially accounts for our nocturnal IOP spikes. Can we use prostaglandin analogs to try to maintain uveoscleral outflow and prevent nocturnal IOP spikes? And then finally, do prostaglandin analogs work? On the right, you're looking at a study that's published in The Lancet. This is the United Kingdom glaucoma treatment study. Over 500 patients with newly diagnosed primary open-angle glaucoma were randomized to either latanoprost once a day or placebo once a day. And they looked at visual field loss or visual field progression over time. And not surprisingly, latanoprost once a day outperformed placebo in lessening visual field progression. It was an over 50% reduction in visual field loss. And so let's review a couple of our newish topical prostaglandin analog options. First, we're going to start with latanoprost preservative-free, or IUSA. This was FDA approved in 2023. It's our first fully preservative-free, commercially available latanoprost and prostaglandin option. It's targeting uveoscleral outflow and is once daily dosed. On the right, you can see the pivotal FDA clinical trial. So they compared latanoprost preservative-free compared to name brand Xalatan or branded latanoprost. And looking at IOP lowering, the preservative-free latanoprost lowered IOP by 3 to 8 millimeters of mercury compared to 4 to 8 in the Xalatan group. And so one of the conceptual or theories around preservative-free drops is we know that one of the goals of the preservative is to maintain sterility or keep microbes out of the bottle. But another one is preservatives do help break down the epithelial tight junctions, get penetration of this medication. And so do we lose efficacy by going to preservative-free? Very comparable in this study. And then how about ocular adverse reactions? This study looked at conjunctival hyperemia, so redness. Are you going to see more redness using a name brand medication? Sorry, I just lost my slides here. Let me see if I can get back to it. Disabled. I just lost my slides here, Ariel. Let's see if I can pull them back up.
Okay.
I'm going to share screen. Can you see them here?
Yes.
Okay. I can see them as well. I'm just in a different spot now to where I can see you rather than my slides. How do I get back there, I wonder? I got it. We're good.
Okay. Perfect.
Thank you. Sorry about that, guys. And so conjunctival hyperemia, what do we need to know here? it was about the same between a branded prostaglandin analog and a preservative-free. And so maybe that means that it's actually more of the prostaglandin molecule leading to hyperemia rather than the preservative. What was different, though, is eye irritation. And so discomfort with topical glaucoma drops, as well as ocular surface disease composite score, much lower in the patients who are on a preservative-free option. It was more tolerable from an ocular surface disease standpoint. A second newish option, this is older now, but a second newish option is latanoprostene Bunad 0.024%, which makes commercially Vyzulta. Vyzulta combines a prostaglandin analog, so we're getting uveoscleral outflow, with a nitric oxide donor component. And so nitric oxide helps to relax and expand the trabecular meshwork cytoskeleton. In glaucomatous eyes, they've shown that nitric oxide is decreased in the amount in the trabecular meshwork, Schlemm's canal, and the ciliary body. And so if we can add exogenous or outside nitric oxide, can we increase both uveoscleral outflow because of the PGA component, as well as trabecular meshwork outflow due to that nitric oxide? And so on the right, you're looking at the Voyager study. This compared latanoprostene Bunad at various concentrations compared to latanoprost. IOP lowering was statistically significant in favor of latanoprostene Bunad or Vyzulta, an additional 1.5 to 2 millimeters of mercury over latanoprost. But the bar graph you're looking at is the adverse events or safety data. And I think the conclusion for me is Vyzulta is very tolerable in my clinical experience. Patients do very well on this medication. There's minimal side effects. You can see here from the Voyager study, the most common Vyzulta side effect was site installation pain or burning and stinging on putting in the medication. And then for latanoprost did quite well in this study, with ocular hyperemia being the number one at 8.5%. Two other new-ish topical glaucoma drops in the US. This makes up our newest category of topical glaucoma drops, which is going to be Rho kinase inhibitors. And so Notarcetal 0.02%, which makes Rhopressa, and Notarcetal 0.02% and latanoprost, which makes Rocklatan. Both of these medications, as I said, are Rho kinase inhibitors. Rho kinases work with their primary mechanism of action on the trabecular meshwork. The goal of Rho kinase inhibition is to relax and expand the trabecular meshwork, a less contracted fibrotic TM, so that there's more spacing in the trabecular meshwork for fluid to flow out. Notarcetal has also been shown to work on episcleral veins. And then finally, if we add in the latanoprost component in Rocklatan, now we're getting uveoscleral outflow. And so really three mechanisms of action with Rocklatan to lower IOP, but the primary is going to be working on the trabecular meshwork. And so we're going to focus solely here on Rocklatan. This combines, again, Notarcetal and latanoprost. Rocklatan has the Mercury trials, Mercury 1 and Mercury 2. These are large trials. Each had over 700 patients, and the Mercury trials compared Rocklatan to each of its individual components. So Rocklatan once a day was compared to Notarcetal once a day, was compared to latanoprost once a day. Patients randomized 1 to 1 to 1. And Rocklatan did show superior IOP lowering compared to latanoprost at all time points. What you're looking at here is benchmarking IOP, so greater than or equal to 20%, which is a large benchmark that the FDA uses for any new laser drop procedure coming to market in glaucoma. You have to get this greater than or equal to 20% reduction. And you can see Rocklatan, 87% of patients achieved that. We would expect that. It has a prostaglandin analog. But now if we go to greater than or equal to 30%, shown in blue, almost 2/3 of patients got that. And then how about your toughest patients, where we're trying to get an over 40% reduction in IOP with Rocklatan once daily? About 31% of patients achieved that. And so we're going to move out of the topical drop space. I said 4 common ways that we're going to treat open angle glaucoma. We're moving on now to laser trabeculoplasty. This is almost exclusively now selective laser trabeculoplasty. ALT is pretty archaic now. And I think of SLT as really using laser energy to kind of clean out and rejuvenate our patient's natural outflow pathway. We're going to clean out the trabecular meshwork to ultimately help the eyes drain work better. SLT's mechanism of action maybe isn't fully understood, and it's probably multifactorial. But I think of SLT as using laser energy to target and pigmented trabecular meshwork cells, give them these laser burns, kind of change the anatomy. SLT activates inflammation to lower IOP, and then SLT has been shown to cause a macrophage uptick. Think of little Pac-Men and women that come and clean out the drain is the macrophages. And so when I talk about SLT with patients, I'll use the analogy of a sink in the eye for glaucoma. There's a faucet or pump that makes fluid and then a drain that drains it out. We're going to use the laser to kind of clean out and rejuvenate our patient's drain. Does SLT work? What's the efficacy? And so 2 studies here. First on the top right, this is the McElrath study published in the Journal of Glaucoma. This is 100 newly diagnosed open-angle glaucoma patients. They're treatment naive, randomized 3-to-1. So 75 patients had SLT, 25 patients had latanoprost once a day. Baseline IOP right around 25 millimeters of mercury, and SLT was about equal to latanoprost. Both got about a 30% reduction in IOP. And so that's how I think about it in clinic. SLT is equal to about 1 prostaglandin analog drop. On the bottom left, this is the Melamed study. And the reason that I showed this bar graph is because 5 years ago, I used to say, if we do SLT with a patient, I'm talking in the exam lane now, I would say if we do SLT, I think we have an 80% chance to reduce your eye pressure by about 5 points. This study, with a pretreatment IOP of 25 millimeters of mercury, said greater than 5 millimeters of mercury IOP reduction, shown in green, was about 90% of patients. And so now I say 90% of patients are going to achieve this. On the far left, a patient who got 1 to 2 millimeters of mercury of IOP reduction or less, about 4%. And so 1 out of maybe 15 patients, maybe 1 out of 20 patients is not going to get a big response, but we're in the same spot that we were before. If we think about SLT, like many of our topical glaucoma drops, like our MIGS procedures, where you start with the baseline IOP matters. With SLT, the higher the pre-laser IOP, the bigger absolute millimeters of mercury reduction I expect to get. And so here's a procedural video of SLT. It's a frequency doubled YAG laser, wavelength of about 532 microns. Commonly, I'm going to use a power of 0.8 millijoules to start, and then I'll titrate up to 1. Spot size 400 microns. Anatomy is important here. And so remember, we're trying to use laser energy targeted at the trabecular meshwork. So we really have to be able to see the TM well. You're going to use a gonioscopy mirror with conventional SLT. So you can see us going here. I prefer a 4-mirror gonioscopy lens for SLT. You can get a 3-mirror as well. And so finding that trabecular meshwork, I do about 10 to 12 shots per quadrant, and then I'm going to rotate 45 degrees and do the oblique angles, but hoping to get about 100 shots of laser energy. And so you can see here, we'll rotate in just a second. And so this is where you're going to see our visual feedback. Those little bubbles coming back, we call them champagne bubbles. That tells me that I'm getting a laser response. And so I'm going to titrate up my energy till I start to see those laser bubbles or those champagne bubbles coming back. And I want to see that in about 20 to 25% of the shots that I do. And so there's a procedural video there. Let's look at some more data here. This is the LIGHT trial. This is a really powerful trial for both safety and efficacy in SLT. This was a study done in Europe, over 700 patients, newly diagnosed glaucoma. And they looked at SLT versus starting topical glaucoma drops. Patients were randomized 1-to-1 SLT versus drops. And the primary endpoint of the study was patient quality of life. They used some different glaucoma quality of life index scores, and the primary endpoint of this study was at 3 years. We'll also look at the extension study here coming up. And so for quality of life between patients who had SLT versus patients who had drops for glaucoma, I think to many of our surprise, there was no statistical significance in difference. It was pretty equal in these glaucoma quality of life scores. On the top left, you're looking at the percentage of patients who are at IOP target. And so in the SLT group, 95% of patients were at target, and almost 80% of patients were medication free out to 3 years. In the drops group, 93% of patients at target, and about 2/3 of patients are on only one medication. This study also looked at progression in glaucoma over 3 years in the drops group. About 6% of patients progressed in their severity in glaucoma. It was about 4% in the SLT group. And then I think the biggest take home from the 3-year endpoint is cost. Again, the study was done in Europe, so it's measured in euros, but at 36 months, the study in the discussion says that SLT was about half the cost of drops, and with a 97% probability, they could say out to 3 years, they concluded that SLT was more cost-effective than drops for patients and payers. Here's the 6-year study update for the LIGHT trial, and so 633 subjects of the over 700 in the initial entered the 3-year extension study. At the beginning of the extension study, so month 37, in the SLT group, 128 had a second SLT to decrease drop burden, and 48 received SLT as treatment escalation. In the medication group, 320 patients, quality of life scores shown on the bottom right, still non-statistically significant. And so still no big difference between the two. And so quality of life scores remain the same at 6 years, but I think treatment efficacy really starts to show a spread here in favor of SLT. On the right, this is the percentage of patients who had progression in their glaucoma. In the SLT group, 19.6% of patients had progression. In the med group, 26.8% of patients had progression. So about a 7% difference there. On the right, the percentage of patients who needed to go on to further glaucoma surgery. This is important because in the LIGHT trial, progression in glaucoma surgery was incisional glaucoma surgery. So tubes, trabs, shunts, bigger glaucoma surgeries. SLT, 2.4% of patients compared to in the med group, 5.8% of patients needed to go on to a bigger glaucoma surgery. And then finally, patients who are increasing or escalating their therapy. In the SLT group, at 6 years, 70% of patients were medication-free. Remember, they could have a second SLT, but medication-free at 6 years. In the drops group, patients who were on solely one topical glaucoma drop at year 6 was only 18%. And so 80% of patients are on 2 or more drops here by year 6. One of my favorite parts with SLT is it's very, very safe. It is a laser procedure, though, and so it's not zero risk. On the top left, we're going to talk about direct SLT. The big adverse event to know at DSLT is these little petechial hemorrhages at the limbus. And then for conventional SLT, I think your big 3 for adverse events is going to be patients having a little bit of post-op discomfort, patients having a little bit of post-op inflammation. And so you can see some KP here, having a little bit of cell in the anterior chamber. And then on the bottom right, immediately after SLT, you can see an IOP spike in about 10% of patients, according to this study here. For SLT in our practice, after SLT, we're usually going to stop one topical drop. Most commonly, it's the drop that the patient's dosing the most. I think you can have drops be adjunctive or helpful. You can use these in combination with SLT, but I'm usually going to stop at twice a day or a 3 times a day drop for a patient and then recheck the eye pressure, find kind of the new baseline IOP about 6 weeks after SLT for most patients. And so what's new in SLT? In December of 2023, the FDA approved Belkin's Eagle Direct SLT, which is now a product of Alcon called Voyager SLT. This is a direct selective laser trabeculoplasty. What that means is there's no gonioscopy mirror put onto the eye. It's a non-contact SLT. It delivers 120 automated shots to the limbal area in about 3.5 seconds. On the bottom, this is the Glorious trial. We're going to look at the data here. And so in the Glorious trial, they were comparing SLT versus direct SLT. The primary endpoint was to look at the DSLT outcomes and prove non-inferiority to conventional SLT done with a mirrored lens. In the DSLT group, patients had 120 automated shots at a power of 1.7 millijoules. In the conventional mirrored SLT group, they had 100 laser shots at 0.9 millijoules. Primary endpoint was the difference in mean IOP reduction from a washed out baseline IOP at 6 months. You can see the secondary endpoints. On the right, patient parameters, about 80 patients in each group. Screening IOP was medicated in the DSLT group, about 21.5, in the SLT group, 20.5. And so we'll just average those to about 21. Washed out IOP right around 26. And then on average, patients were on about 1 topical glaucoma drop before they had laser. Here is your efficacy results. And so on the left, this is your primary endpoint, the IOP change from baseline, washed out IOP at month 6. On the top in the DSLT group, baseline IOP of 26.5 millimeters of mercury. Patients got about a 5.5 millimeter of mercury IOP reduction. It's about a 20% reduction from a washed out or unmedicated baseline IOP. In the SLT group, from 26 millimeters of mercury down to just under 20, a 6.2 millimeter of mercury reduction, a 24% reduction from an unmedicated baseline at 6 months with conventional SLT. On the right, this is the IOP change from screening with a non-washed out IOP at month 12. Both groups got about a 3.2 millimeter of mercury IOP reduction. And so here's DSLT in my practice, performing it on a patient. All right, we'll bring his chin down quite a bit. Awesome, that is good. A little more chin. Good. All right, 3 seconds. Click, snap, and a burn. You can rest. And so I think summarizing that procedural video there, this is extremely efficient for patients and for the practice. This can happen in the same day. In our practice, we do bilateral DSLT. That patient, before we saw it in the video, had a drop of proparacaine, a drop of tetracaine, had an artificial tear. It's really important that you have a good image so that we can acquire kind of where the limbus is at. And then I'll very commonly manually change my treatment ring just a little bit. We talked earlier, patients can have some hemorrhages, especially if you're on the more conjunctival side of the limbus. You can sometimes nick a blood vessel here. But I think the biggest win with DSLT is how fast it is in the patient experience and the practice experience. And so our third category for a patient with primary open angle glaucoma, a very good first line treatment, but doesn't have to be. You can use this later in the glaucoma journey as well as drug delivery. I think drug delivery is really a treatment category that could shift the paradigm in pharmacologic treatment in glaucoma. I think this definitely fits into first line therapy. I think as optometrists, we should be excited about drug delivery in glaucoma because there are some technologies that maybe now fit into your scope of practice, depending on the state that you practice, or definitely in the future, if things like a conjunctival ring and punctal plugs come to market, that we're going to be doing. And so I think drug delivery in glaucoma really has 2 goals. Number 1, to increase medication adherence, so take non-compliance down to close to 0. If we can get the medication to slowly dissolve, elute, release, over time, we know a patient's going to get it. And then second, less preservatives on the front part of the eye is going to hopefully lead to less ocular surface disease, less patient side effects. But an important point to know is there's only 2 FDA approved at this time. One is labeled for single use. One does have FDA labeling for repeat procedure, and we'll call out those nuances. And so our first, the trailblazer in drug delivery in glaucoma is bimatoprost SR. Commercially, we know this as Durysta. This was the first one. It was the first one to get FDA approved, the first one that was commercially available. Durysta is a biodegradable bimatoprost sustained release implant. And so it's injected intracamerally. And so surgeon in our practice will make a small incision. You'll see a video, put this in. It's almost like clicking a button on a lead pencil, drops this little pellet down into the inferior angle. It's freely floating. FDA approved and indicated to reduce IOP in patients with open angle glaucoma or ocular hypertension. It's important to note that it's labeled by the FDA as single intracameral administration. There was concern of stacking pellets and endothelial cell loss. And so it is a one-time kind of use it and then it's gone as far as what the FDA labeling says. We have done some repeats in our practice. Insurance coverage can get tricky here. On the bottom left, this is early phase 1-2 data from what's called the Artemis trials. This was 150 eyes, 75 patients, and it's a contralateral eye study. And so in one eye, patients had bimatoprost SR at various concentrations, and the other eye, they had topical bimatoprost 1 time per day. Initially, in the patients in the eyes that had bimatoprost SR, they got about an 8 millimeter of mercury IOP reduction out to 1 month, about 6 millimeters of mercury still at 3 months. And then over 30% of patients maintained IOP lowering out to 12 months. Here's what you see on kind of clinical images. These are gonioscopy views. You can sometimes see this in the inferior angle without a mirrored gonioscopy lens as well. But one of my favorite parts about bimatoprost SR or Durysta is it is fully dissolvable. It's fully going to go away. And so moving from top left to bottom right, here is kind of the dissolving part of this collagen matrix that is going to have bimatoprost. In many of my patients, as it's kind of dissolving, it will become more circular rather than a pellet. It's kind of more like a little ball. And there's evidence that the medication runs out before this husk or the kind of carcass of this is left behind. And so with bimatoprost, maybe there's some angle kind of anatomy changing. Maybe it's causing some tissue changes in the trabecular meshwork even after the medication has technically run out. And so here's in-office implantation. This is one of our previous surgical fellows. This eye's previously been anesthetized. We've done a betadine wash. He doesn't use a lid speculum. Many of our glaucoma surgeons do. This looks like a 27 gauge needle. And so bevel up here, he's going to enter in at the limbus. Avoid touching the iris or the endothelium. So you got to stay in between that space. He's going to click a button here, and if you look real closely, you'll see a pellet drop into the inferior angle. There it goes. And so we do this in office. We don't go into the surgery center for this. We'll do one eye at a time. We'll bring that patient back the next day if we're going to do the contralateral eye. That patient can go out to lunch afterwards. And my goal with bimatoprost SR and what I see in my clinical experience is really to get about 9 to 12 months of efficacy for a patient. Like many things in glaucoma, tends to work best in patients who are earlier in the disease process, more mild glaucoma, and it's going to replace one topical glaucoma drop. And so here's the Argos study. I think this is an interesting study. It's published in the Journal of Drugs in 2025. This is 217 patients where they wanted to look at the efficacy of a single Durysta implantation. Couple important keys about the methods here. And so this is more kind of mild glaucoma, mean age of 73, 2-to-1 pseudophakic to phakic patients. And so most of the patients, 2-to-1, so 66% of patients in this clinical trial were already post-cataract surgery. In my practice, it's probably 90-10 that I'm doing Durysta in. 90% of patients have already had cataract surgery, maybe 10% still have their natural lens in place. And the mean deviation on visual field here was -3 decibels in this study. And so much more mild glaucoma. On the left, this bar graph, what you're looking at is the proportion of eyes who needed no additional treatment. So after they implanted Durysta. They didn't have to stop their medications, but what percentage of patients needed more? And almost 80% of patients out to 18 months didn't need escalation of therapy after Durysta was implanted. I think this is kind of the money bar or line graph here. This is a continuation of the Argos study. And you can see this is the IOP bell curve here at baseline, shown in purple, right around 17 millimeters of mercury. Patients weren't washed off their medications at baseline, average of 1.8 topical glaucoma drops. And then you can see month 6, month 12, and month 18 shown in red, and then the dashed green and purple lines. It's moving to the left. Moving this IOP bell curve to the left is lowering IOP out to 18 months. And then on the right, baseline topical number of glaucoma medications, 1.8 out to month 18. Patients almost got off one full bottle of medication out to 18 months. And so Bimatoprost SR was our first. Now this is our second FDA-approved drug delivery device, which is Travoprost SR or iDose. This is approved in December of 2023. This is a product from Glaucoma. You can see the announcement there. And this is a 75 microgram intracameral implant. I think of it as this titanium little canister that holds medication. It has this scleral or trabecular meshwork anchor that you're going to push in as well. It's labeled by the FDA for the reduction of IOP in ocular hypertension or open angle glaucoma patients. Here's the phase 3 studies. Over 1,000 patients in the phase 3 clinical trials. They compared iDose at different elution rates compared to timolol twice a day. iDose lowered IOP 6.6 to 8.4 millimeters of mercury at 3 months, and 81% of patients solely used iDose out to 12 months. Here's the phase 2 FDA clinical trials. And so at Vance Thompson Vision in Sioux Falls, the surgeon that I worked directly with, we were part of the phase 2B clinical trials, and then both of the phase 3 clinical trials. And so this is data from phase 2, 154 subjects, ocular hypertension or mild to moderate open angle glaucoma, washed out IOP of about 25 millimeters of mercury. Patients were randomized 1 to 1 to 1. iDose fast elution versus slow elution rate versus timolol twice a day. And at 6, 12, and 24 months, iDose lowered IOP about 30% from baseline, about 8 millimeters of mercury. There was a statistically significant amount of iDose patients compared to timolol who achieved a greater than or equal to 40% reduction in IOP. And then in the timolol group at month 24, this timolol group had instilled about 1,500 more drops compared to the patients who had iDose. Here's an insertion video here. This is a 2 to 3 minute procedure. Big key here is iDose is done in our ambulatory surgical center. So patients do go into the operating room for this. It's about a 2.5 millimeter incision. Gonioscopy lens or prism put on the eye, going to find the trabecular meshwork, push in that scleral anchor, and then kind of nudge it back and forth. Postoperatively, most commonly, this is going to sit supranasal. So we kind of tuck it up supranasal so that hopefully it sits under the eyelid. With the naked eye, very unlikely that you're going to see this, but this is something that you will see in the anterior chamber with a slit lamp. With microscopy and having magnification, you'll be able to see this without putting a gonioscopy mirror onto the eye. And so with our 2 FDA-approved drug delivery options we have right now, just to summarize, Bimatoprost SR, about a year of IOP lowering, but it's done in the clinic. Nothing stays behind. With iDose, this is done in our ASC. We get about 3 years of runway for IOP lowering, and there is a titanium canister that is left behind. And so about patient attitude towards drug delivery. This is about 200 patients who volunteered to take an administered interviewer survey. So someone was calling them to ask these survey questions about their attitudes toward drug delivery. Important for the methods. Some of the patients that were selected were our normal control, so non-glaucomatous eyes. Some of the patients selected for this interviewer administered survey had mild glaucoma, but no surgical history. Some patients who took the survey had glaucoma with incisional glaucoma surgery history. And so this was their attitude about adopting new technologies in the drug delivery space. And so by far and away, most common option that patients said, yes, I'm willing to do that, was using combination eye drops, putting multiple molecules into one bottle. About half of patients said yes, microdose eye spray. And then you can see other drug delivery options here. The overall take home, though, one of the big conclusions was the more glaucoma severity a patient had, as well as the more surgical history a glaucoma patient had, the more likely they were to say, yes, I want to move towards drug delivery. And then finally, what about minimally invasive glaucoma surgeries or MIGS? Very rarely is intraocular surgery going to be first line treatment. But I do think there's a scenario that's becoming more common in our practice where a patient comes in for a cataract evaluation and we're also diagnosing them with mild glaucoma at that same time, or ocular hypertension in the situation of iDose. And so these patients come in, they have a visually significant cataract, they also have mild to moderate glaucoma. I think MIGS has to be considered here. And so let's define minimally invasive glaucoma surgeries or MIGS. These are procedures that take an ab interno approach. What that means is a surgeon is going to use a gonio prism. They're going to view the inside of the eye and then most commonly work inside to out. MIGS procedures want to intervene earlier in the disease process and provide a minimally traumatic, similar to cataract surgery alone, extremely safe glaucoma surgery that provides at least modest efficacy for IOP lowering. We want the recovery and the risk to be similar to cataract surgery. And you'll see that's how they're compared. MIGS are really, really safe for glaucoma patients. So I do think you can consider them first line in some scenarios. These are microscopic devices. You can see the stent options that we have on the bottom left in comparison to the size of a penny. I think my glaucoma practice is jam-packed with MIGS patients who have MIGS at the time of cataract surgery. But really the first key to understanding, am I going to refer this patient for minimally invasive glaucoma surgeries, is what is the state of the natural crystalline lens? On the left, remember that cataract surgery alone lowers IOP. About 2 to 4 millimeters of mercury, depends on where you start for a baseline IOP. And MIGS can couple very nicely with cataract surgery to try to further increase aqueous outflow with some of our trabecular meshwork bypass stents. You can do goniotomies, you can do canaloplasties. You can also use cataract surgery and laser to try to turn down aqueous production. And so I think of a patient who has a visually significant cataract, think MIGS. Patient who is highly hyperopic, use cataract surgery earlier. A patient who has recalcitrant glaucoma, or we can't get their glaucoma under control, they have narrow angles, use phaco earlier and then combine it with MIGS. And then on the right, pseudophakic, minimally invasive glaucoma surgery options. MIGS is not only at the time of cataract surgery. You can come back and do stenting options with iStent Infinite. You can do goniotomies, canaloplasties, Omni. We have lots of options for the patient who's already had cataract surgery as well. And so how do we get there? In the open angle glaucoma patient, we talked about drops, we talked about laser, drug delivery, glaucoma surgery. What should our plan be? And so I think an overarching theme for me is make a custom treatment plan for each patient, set targets, and then think about some of these factors. First, age. Age should be a determining factor in how you're thinking about prescribing or making a treatment plan in glaucoma. It's risk versus reward. I have to take, unfortunately, more risk in this 35-year-old patient to maintain vision and visual field throughout this patient's life. Glaucoma wants to get worse, and I just have more years of trying to keep non-progressing glaucoma in a 35-year-old compared to a 75-year-old. That patient on the bottom also doesn't scar as quickly. Healing could be easier or tougher depending on what you're doing. Number two, what's the state of the natural crystalline lens? I think of a lot of glaucoma treatment as really three phases of life. I have a patient who has a clear lens. We don't have a visually significant cataract. I need to have treatments that are going to bridge until the time of cataract surgery plus MIGS. That's kind of phase 2. And then after cataract surgery plus MIGS, glaucoma wants to worsen. And so now how am I going to take care of the pseudophakic patient? Corneal hysteresis, there's good studies that have shown corneal hysteresis is a factor of how likely a patient is to progress. Patients who have a low baseline corneal hysteresis have a higher risk of progression. And so I change my treatment aggressiveness based on hysteresis. Disease severity. Unfortunately, bad glaucoma wants to get more bad or worse. And so these patients with higher baseline IOPs, the patient who comes to see you with moderate to severe glaucoma, is just at a higher risk of progression. And then baseline IOP may determine the treatment approach that we're going to take. We treat low pressure glaucoma differently than we do the patient who has a pressure of 26. Frankly, that patient whose IOP is 26 is much easier because we have a higher gradient to lower the IOP to. And then ocular perfusion pressure doesn't really help me make decisions right now. I think it's mostly mathematical modeling, but how do we work on perfusion pressure down the road? And then what do our patients want? Because ultimately we're going to recommend or prescribe a treatment, but if our patient in front of us is unwilling to do it, we're kind of stuck. And so this was a study that was done at the University of Colorado at Denver on patient preference for glaucoma treatment. And I think there are some interesting findings here. First, if they compare drops to drug delivery, 55% of patients said, yes, I want to start topical glaucoma drops first. 45% of patients said, I would like to lead with drug delivery. Second, when specifically deciding between a device implanted into the eye, a drug delivery reservoir that goes into the eye, versus something that's external, like a conjunctival ring or a punctal plug, patients had a strong preference to external devices, even if it meant a shorter treatment duration. SLT was viewed as surgery in this. And so they asked patients, would you rather have surgery inside the eye or SLT? Not surprisingly, most patients chose SLT. And so really, I think our job is to meet patients at their moment of vulnerability and ultimately prescribe a treatment plan that they are on board with, because you want the patient to be on your team. You want them to be invested. Otherwise, compliance, adherence, coming back to see you just goes down. And so how do I choose in the open angle glaucoma patient? Here's 3 factors that I really think through as I'm trying to make a treatment plan for a patient with open angle glaucoma. And so after analyzing the previous slides, on the top left, compliance. Topical glaucoma drops are a big part of my practice. They are a must in glaucoma, but topical drop compliance is not good with patients. And so if it's a first line treatment, I'll often lead with SLT in my practice. This study on the left, this is out of the University of Michigan at the Kellogg Eye Institute, where they looked at over 1,000 patients with newly diagnosed open angle glaucoma. They were started on one topical glaucoma drop, and then they assessed adherence to medication at 1 year and 4 years. And they defined persistently good adherence with topical glaucoma drops. And at 1 year after starting a medication, it was 20%, and it drops to 15% at 4 years. 80 to 85% of our patients are non-compliant in this study. Second, cost. Unfortunately, cost greatly affects compliance. If our patients can't afford to get the medication or do the surgery, well, again, we're not going to move forward. Comparing SLT cost versus drop cost, we said that in the LIGHT trial, they showed that SLT is more cost-effective than drops in treating first-line glaucoma. There are studies by Ike Ahmed and others in the surgical space that said cataract surgery plus MIGS, combining them at the time of cataract surgery, is more cost-effective than using cataract surgery plus medications to treat glaucoma. And then finally, what can buy me longevity? What can buy me the most years of non-progressing glaucoma? Drops can work for a long time. Laser trabeculoplasty mostly has a runway of 3 to 5 years. It is repeatable. There's some studies being done on using it yearly to try to have repeat SLT be more of a continued treatment. What about surgery? Do we want to be going into surgery every year or every 2 years? And so all of these play a role. And in my prescribing a treatment plan, I'm very careful not to pin one treatment option versus the other. I rarely think of it as drops versus SLT or SLT versus drug delivery. Because if we go back to that 45 or 55-year-old that we diagnose with glaucoma, we're going to need 2, 3, sometimes all 4 of our treatment options to keep non-progressing glaucoma for a patient. And so rather than one versus the other, it's more, where do I put them in the line of that patient's glaucoma journey? And so we covered open angle glaucoma on the left. These patients where we can access the conventional outflow pathway. We have lots of drops and laser and drug delivery and surgical options here. But what about this patient on the right? We have a closed angle. This is a more urgent glaucoma. It's more volatile. This patient can progress quickly. They're very commonly going to have at least episodic eye pressures of 40 or 55. This type of glaucoma on the right usually comes with more visual field loss when they're coming to our practices. And so we're going to zoom back out, big picture here. What is acute glaucoma? Acute glaucoma is really angle closure glaucoma. In the definition, we have an acute block or blockade that's preventing aqueous from getting from the posterior segment into the anterior chamber and ultimately draining out. We have some type of appositional or syncytial blockage of the anterior chamber drain, and it's going to result in elevated IOP. This is what we call an ocular emergency. It requires immediate attention. There's high risk for irreversible vision loss. If we think of some of our other ocular emergencies, we have a retinal detachment, a central retinal artery occlusion, an alkali burn on the eye, other ischemic optic neuropathies, etc. If a patient calls Friday night at 10:30 with one of these, you have to go in and see them or have a referral plan. How common is angle closure glaucoma worldwide? Less than 1% of individuals, so 0.7% of individuals over the age of 40 will have an angle closure glaucoma attack or chronic disease. 20 million people worldwide have angle closure glaucoma, with about 15 million of those patients being in Asia. And so that's where we're at now, but where are we going? Angle closure glaucoma is expected to double in volume by the year 2040. Worldwide, we're going to increase from 20 million to 40 million patients with angle closure glaucoma, with about 5 million patients estimated to go blind due to angle closure glaucoma by the year 2040. Who is at risk of angle closure glaucoma? There's definitely a genetic component or a family history risk to angle closure glaucoma. It's likely related to the axial length or that patient's refractive error. And so the length of the eye plays a big part. Age. Increasing age is a risk factor for angle closure attacks and angle closure glaucoma. A lot of this probably hinges on the status of the natural crystalline lens. Remember that as our lens in the eye becomes a cataract, it's like a cyst that's growing. It increases in size, puts us at more risk. Females more than males for angle closure attacks in glaucoma. Women are about 2 times more likely than men to have angle closure glaucoma. Hyperopic refractive error because of a shallow anterior chamber angle. You can see this picture to the right, this hyperopic eye. It's a shortened eye. Remember, we have the same anatomy in the eye, but the axial length is less, and so everything gets compressed. You can see the angles there being very narrow. And then ethnicity. Ethnicity definitely plays a role. You can see your most common ones to know on the bottom there. The prevalence of angle closure glaucoma in Inuit or Asian patients is just much higher. It's about 1 in 100 patients in those ethnicities, compared to angle closure in a patient who's European or Caucasian descent is about 1 in 1,000. What does the angle closure glaucoma patient look like? First, what are the symptoms? Then what are the signs? And so this patient's going to call into your office in pain and discomfort. They have blurred vision. They want to come in urgently. Chief complaint may be eye pain, light sensitivity, headache. They feel nauseous, like they're going to throw up. In my experience, if you have a patient who has previous ocular pathology or is in the perioperative period of having some type of eye surgery, they call your office and they have kind of a brow ache. They feel nauseous, like they're going to throw up. eye pressure has to be very high on your list for culprits. And so rule out high IOP in that patient with brow ache, nausea, and vomiting. Signs of angle closure glaucoma or an angle closure attack. This is actually pictures from one of my patients here shown to the left. And so conjunctival hyperemia tends to be kind of a red. You'll have these dilated episcleral and conjunctival vessels here. They can often have a mid-dilated and sluggish or fixed pupil if they're an angle closure. Corneal edema, you're going to have a swollen, boggy cornea. Remember that as the IOP goes up, the endothelial cell pump function goes down. And so these patients will tend to have corneal edema. As that edema goes from the posterior of the cornea to the anterior of the cornea, you're going to see microcystic edema and sometimes bullae, elevated IOP, and a narrow von Herrick angle. Let's go through some definitions here. Primary versus secondary angle closure glaucoma. Primary angle closure glaucoma is most commonly going to be pupillary block. You have the lens blocking fluid from getting to the posterior chamber to the anterior chamber. And so much more going to see primary angle closure glaucoma in a patient who is hyperopic, has a shorter axial length, and is phakic, has their natural crystalline lens in place. And then secondary angle closure glaucoma, this is non-pupillary block, tends to be more synechial or some type of apposition of tissue because of inflammation, because of neovascularization, could be fibrovascular tissue, something else, but not the lens, is causing this synechia or iris to get pulled up on top of or over the trabecular meshwork here. And so let's go through a case here. This is a patient that was referred into our practice, patient RM. He's a 53-year-old male, comes in with uncontrolled IOP. In talking with the patient, he says, I was started on one topical glaucoma drop to lower my pressure, but it didn't come down. So my doctor put on a second topical glaucoma drop to lower my pressure. It didn't come down. They put on a third topical glaucoma drop to lower my pressure. It didn't come down. So I'm coming to see you to know which should be our fourth drop to put on the eye. Applanation tonometry of 23 in the right eye, 22 in the left. 3 months ago, the IOP, though, was 39 and 40, and his Tmax is 44 and 50. Currently on a prostaglandin analog once a day, an alpha-2 adrenergic twice a day, and a CAI twice a day, all in both eyes. You can see pachymetry average to thick, refractive error +2 1/4, -1/4 at 33 in his right eye, and +250 in his left. Here's what his cornea looks like. And so it's still a little bit boggy, even though he has a normal IOP or near normal IOP today on multiple topical drops. Here is his von Herrick angle here. And so what's my next step? Which drop should I add here? We have 2 aqueous suppressants on board. We have a prostaglandin analog on board. Think at home, which drop are you going to add next? Or should we do something else? And so I decided to put a gonioscopy lens on this eye, and here's what we see. This is your superior mirror, inferior angle. There's no structures viewed here. All quadrants look very similar, and so we have no structures. This was a humbling reminder of how difficult it is to get slit lamp photos through a gonioscopy mirror and a swollen cornea. But this is a patient who's going in and out of angle closure attacks. This patient's having episodic IOP spikes, depending on the time of day, probably the lighting situations. When those episodic IOP spikes happen because the angle closes off, the cornea becomes swollen, and he's losing quality of vision. And so in this patient, you can add all of the topical glaucoma drops that you want, but when that patient goes into angle closure, the IOP is going to be going up. The key to this case is gonioscopy. Get comfortable and confident with a gonioscopy lens. Be able to do gonioscopy. Remember our anatomy. So working from posterior, from the iris to anterior here, you can see the iris, the ciliary body, the scleral spur, and then the trabecular meshwork. When I do gonioscopy, I like to find the scleral spur, this bright white band in between our 2 pigmented landmarks of ciliary body and trabecular meshwork. That's where I'm going to start. Working from posterior to anterior, the mnemonic I remember learning was I can see that line. There's other ones that tend to have more demonstrative words in them, but I can see that line is what I remember here. And then finally, in your chart, you really can't code primary open angle glaucoma if you haven't assessed the angle. If you don't know if it's open, we can't on ICD-10 coding say this is open angle glaucoma. What about anterior segment OCT? I'm a fan of doing dynamic gonioscopy to assess the angle. I like to press a little bit, see if I can open the angle, be able to look for pigmentation of the angle, etc. But you can definitely get some added value by doing anterior segment OCT. It's going to really show the relationship between the iris and the cornea. Shown in kind of light purple in many of these photos is the angle, the trabecular meshwork, and then we're comparing that space in between the iris and the cornea here. Limitations of anterior segment OCT, you really can't clearly see the ciliary body. It's hard to catch mild peripheral anterior synechia or PAS. You can't see neovascularization of the angle, but is helpful in some of these scenarios. And then here is some of our examples. On the top left, this is an open angle on anterior segment OCT. You can see the lens, iris, and then cornea, trabecular meshwork. On the top right, we have a narrow angle. That space is just much less in between the iris and the cornea. And then on the bottom right, a patient who is open, but is actually in what we call Q configuration. The iris is bowing or pushing backwards. It's directly resting on the lens. This is going to cause kind of mechanical rubbing and liberation of pigment. This is common in patients with pigment dispersion and pigmentary glaucoma. Let's get some definitions down for angle closure with primary angle closure suspect or PACS, primary angle closure or PAC, and then primary angle closure glaucoma. And so a patient who's a primary angle closure suspect has greater than 180 degrees of iridotrabecular contact. Iris is touching onto the trabecular meshwork, but a patient who is in PACS does not have elevated IOP or peripheral anterior synechia, and there is no optic nerve damage. There's no glaucomatous change. Primary angle closure. This is a patient who has greater than or equal to 180 degrees of iridotrabecular contact, and this patient now has either elevated IOP or synechia or both, but does not have any glaucomatous damage or visual field loss. And then a patient who has primary angle closure glaucoma has all three. So now we have optic nerve damage or visual field loss. What's our treatment for the patient who has primary angle closure? So that was our patient who came in, wasn't in an angle closure attack when we were seeing them, but had previously. What about topical drops? We're going to use topical aqueous suppressants like beta blockers, alpha-2 adrenergics, carbonic anhydrase inhibitors. You want to throw the kitchen sink of topical glaucoma drops on the eye that's in an angle closure attack. Put everything in your clinic that you have for samples on the eye if a patient's in a primary angle closure attack. Second, miotics. Most commonly, we'd think of this as pilocarpine. This was kind of our second legendary glaucoma drop in the US. It does have an IOP lowering effect, but with pilocarpine and a patient who's in angle closure, we're thinking more about changing the iris configuration. Remember, the iris is kind of like an accordion. When it gets dilated or mid-dilated, it's actually going to take up more space. And so can we use a miotic to kind of stretch out the iris, make the pupil smaller? Osmotic agents like mannitol or glycerin. I've actually never used these in my practice. What I have used a lot of is oral carbonic anhydrase inhibitors like acetazolamide or Diamox, 500 milligrams in a single dose. Try to lower the IOP. Sometimes we'll do that before a patient is going into a surgical approach. And then surgical approaches for angle closure attacks or primary angle closure, we can do a paracentesis, basically just going in with a small needle, making a hole and egressing some fluid out. Iridoplasty, making a hole in the iris. Most commonly, this is going to be a patient who's in pupillary block, and then a clear lens exchange, taking out the lens to open space for fluid to draw out or to drain out. And so the key is after we have a surgical approach, we get the patient out of an angle closure attack, we have to ultimately treat this long-term. So have a long-term treatment approach as well. Let's look at our surgical treatments for primary angle closure. First, a laser iridotomy. This is using a YAG laser to do contraction burns on the iris, basically making a hole in the iris so fluid can get from the posterior to the anterior chamber. Some of our potential adverse events can have hyphema or blood, inflammation, IOP spikes. A YAG laser and a YAG peripheral iridotomy is effective to break pupillary block. Second, a clear lens exchange. Going in, taking out the patient's lens, putting in an IOL or an intraocular lens, you're going to open the angle here. You're also going to put this patient into absolute presbyopia, but it is a long-term fix. These are great UBM photos here, biomicroscopy photos with ultrasound on the bottom. And if you look at the picture, that's kind of a black and white image on the right side, you can see this really big cystic lens closing off the angle. That patient has a clear lens exchange or cataract surgery, and now you can see shown in dark black on the left side of the left picture. This is the IOL. You can see how much it opens the angle just by getting the lens out of the eye. And then finally, filtration surgery. This is just saying our angle is shot. It's toast. We're going to put in a new drain inside the eye. We have the risk of hypotony, tube failure. There's big risks, but it is usually going to get a patient out of angle closure. It's going to have a way to lower the IOP and lessen drops. And so let's go back to our patient that's sitting in front of us. We have a 53-year-old patient. He does not have a visually significant cataract. He's hyperopic. He's had historic IOPs, 40 to 50. Think through this at home. Is this just ocular hypertension? Here's a hint. It's not. Is this primary angle closure, or is this acute angle closure glaucoma? So think through this. I would say that this is primary angle closure. I didn't show you any visual fields or OCTs to show that there's glaucomatous damage. And so this is primary angle closure. Next, this patient sitting in front of you, how are you going to manage primary angle closure? What's our next step? Are you going to refer for a laser peripheral iridotomy, an LPI? Or are you thinking clear lens exchange? Or if this patient did have a cataract, doing cataract surgery? Let's use the effectiveness of early lens extraction for the treatment of primary angle closure glaucoma, or the EAGLE study, as our guidance here. I think this study provides a very nice guidance for how we should take care of this 53-year-old patient. So randomized trial of 419 patients with primary angle closure and primary angle closure glaucoma. Patients were over the age of 50 and did not have a cataract. And so a couple important keys there. No cataract, patient over 50. These patients all have primary angle closure or primary angle closure glaucoma. This is not suspects. In the study, 208 patients got a clear lens exchange. 211 patients had an LPI with topical glaucoma drops. Bullet number 2, in the patients who had a clear lens exchange, they had an additional 1.2 millimeters of IOP lowering, down from a mean IOP of 29.5 down to 16.6. Third bullet, in the patients who are defined as acute angle closure glaucoma patients, and they had a clear lens exchange, they had a 71% reduction in IOP. And then on the right, here's your medications. Patients who had a clear lens exchange, about 40% were on at least one topical glaucoma drop. In the LPI group, about 80% of patients were on at least one topical glaucoma drop. And so let's summarize the EAGLE study here. First, they used the European Quality of Life Index score and the Glaucoma Utility Index score. In patients who had a clear lens exchange, they had better questionnaires as far as quality of life. Patients are happier in the clear lens exchange group. Number 2, although the initial cost was higher for a clear lens exchange, it ended up saving money over time. Secondary surgeries. Patients who had a clear lens exchange had one secondary surgery, which was glaucoma surgery. In the LPI group, 24 secondary surgeries, with most commonly it being cataract surgery, and then a fewer number of medications after a clear lens exchange. And so how do we manage primary angle closure if the patient is 35. Remember, the EAGLE study is all patients who are 50 and older. If we do a clear lens exchange on a 35-year-old, we're taking out their lens. We've just made them an absolute presbyope in a patient who had a pretty good accommodative amplitude before that time. And so here's how I use the EAGLE study, how it affects my practice patterns kind of on a day-to-day. If I have a patient who's over the age of 50 and has primary angle closure glaucoma, this is easy. Clear lens exchange over LPI, that's supported by the EAGLE study. If I have a patient who is over 50, has primary angle closure, no glaucoma, but an IOP over 30, easy, clear lens exchange. Patient who's over 50 has primary angle closure, but the eye pressure is less than 30. I still think clear lens exchange. Why wait until you have a high IOP? If a patient's less than 50, this is where it gets harder, but they have primary angle closure glaucoma, I still think you do a clear lens exchange. Let the glaucoma dictate our treatment plan. We can come back and change the refractive area. We can use bifocals or different IOLs to help here. But if I have a patient who's less than 50, has a primary angle closure attack, but is not a glaucoma patient, I think LPI over clear lens exchange, so that patient maintains their natural lens. How about angle closure? Who's at the risk of closing? What about this patient here? What's our risk of angle closure with this angle shown here? Well, how are we going to assess this? First, on the left, von Herrick angles. Just a refresher here, at the slit lamp using biomicroscopy, we're going to make a very, very bright optic section, and then we're going to put that right on the limbus. And so our optic section beam is shown with the black marker on the left picture. That is going to be what we use as our independent factor here. So this isn't going to change. That's what we're going to use for our scoring. And then we're going to compare that to the size of the shadow that that beam makes. And so we'll commonly say grade 1, grade 2, grade 3, or grade 4 von Herrick angle. The higher the number, the more open the angle is. But how sensitive is von Herrick angles in practice? This study on the bottom was 131 patients. They all had von Herrick angle grading with a trained technician or an eye care provider. And then that same patient had gonioscopy done by an ophthalmology resident, and von Herrick said open angle in as many as 1 out of 8 patients who either had an angle closure attack history or had angle closure glaucoma. And so gonioscopy is more sensitive and specific for angle closure attacks and glaucoma, but who's at risk of closing? What I learned is if you have trabecular meshwork or more in 2 or more quadrants of the angle, you are fine to dilate, fine to monitor this patient. But on gonioscopy, if you have less than trabecular meshwork, which would be no structures, in 3 or more quadrants, this is a patient who is at a high risk for primary angle closure, and you want to refer for an LPI or a clear lens exchange. But should we be doing more LPIs based on gonioscopy? Let's look at the ZAP trials, the Zhongshan angle closure prevention trials. First, why were these studies done? Well, LPI is commonly done for primary angle closure suspects. Should we be doing more LPIs for suspects? Remember, that's your patient who has iridotrabecular contact in 2 or more quadrants. It's unclear if LPI is truly necessary for suspects. What were the main study questions shown on the right? It was to compare LPI versus observation for primary angle closure suspects. And then finally, and I think this is important for what we do in the exam lane every day, is in-clinic dilation a risk for a patient who's a primary angle closure suspect? Here's your methods from the ZAP trials. It was done in 2008. Sample size, almost 900 subjects, 100% Chinese patients in the ZAP studies. And this was a fellow eye study, meaning 1 eye was our control group, 1 eye was our LPI group. Highly female compared to male, 87% and 17%. Those numbers don't add up to 100. These are phakic patients, primary angle closure suspects. They defined it the same way we did earlier. 6 hours of non-visible trabecular meshwork or more, no PAS, no high IOP, no glaucoma. And the follow-up was about 5 years. Here's your results from the ZAP studies. The number that developed primary angle closure attacks, remember these are same patients, one eye had an LPI, one eye was monitored. 19 of the LPI eyes went on to a primary angle closure compared to 36 in the observation group. The cumulative primary angle closure incidence was 4.2 cases per 1,000 eye years. Remember, the study went over 5 years in the LPI group compared to 8 per 1,000 eye years in the observation group. And so LPIs did lessen the number of primary angle closure attacks, but it's very small numbers, 36 and almost 900 eyes over 5 years. The cumulative peripheral anterior synechia incidence, you can see very low in both groups. And then finally, the number of patients who had an angle closure attack after dilation was 1 in almost 900 in the LPI group and 4 in almost 900 in the observation group. And so let's summarize the ZAP trials. Overall, there's a very low incidence of primary angle closure development from a patient who is labeled as a primary angle closure suspect. Number 2, LPI lowered primary angle closure incidence, but the absolute number was very low. This is taken directly from the conclusion of the study. Widespread prophylactic laser peripheral iridotomy for primary angle closure suspects is not recommended. And then finally, in the control group, they had 1 angle closure attack post-dilation in over 1,500 dilations out to 6 years. And so this is very unlikely that we are going to put a patient with primary angle closure suspect into angle closure based on dilation. It's easier to say in my practice because I have 3 or 4 glaucoma surgeons that are ready to do an LPI that same day if we need to. It's a little bit harder to say that this is going to translate to your practice if you're 2 or 3 hours away from a major city where someone's going to get this done. Let's look at another case here. This is patient KA. This is a patient who was referred into our practice. It's a 57-year-old female, and she was referred for dilation secondary to angle closure risk. So this patient said, I haven't been dilated in 5 to 10 years. She's 57 years old, refraction minus 250, minus a quarter at 117, and then minus 250 minus a half at 84. You can see the IOP is normal, 16 in both eyes. The slit lamp exam of the cornea is within normal limits. Von Herrick angle looks open to me. The lens, very early cataracts, nothing visually significant. You can see her cupping on the optic disc photo of the right eye on the top right, visual field on the bottom here. And so this is a patient who does not have glaucomatous change at this time. You're thinking, why was she referred to us? Here's gonioscopy. Scleral spur inferior and superior in the right eye, but no structures, nasal and temporal on the right eye. Left eye, very similar. Scleral spur inferior and superior, but no structures, nasal and temporal. I did gonioscopy on this patient, and I saw this kind of big dip down after the first hump, or what we call a double hump sign. So we got an anterior segment OCT, and this picture shows it beautifully here. And so you can see, if you look on the far left, we have this kind of first hump, it dips down, and then we have this second elevation here. Almost looks like an M to me. And so this is a double hump sign, which you're going to see much more in a patient with plateau iris and plateau iris syndrome. And so let's look at 2 causes of primary angle closure glaucoma that are less common with iris bombay and plateau iris. And so on the left, iris bombay, we have apposition of the lens to the iris or apposition of the iris to the anterior vitreous, which leads to pupillary block. Basically, again, you can't get fluid from the posterior segment to the anterior segment, so aqueous is going to push the whole iris forward here. And so this whole iris gets pushed forward, pushes this patient into pupillary block. On the right, plateau iris, you can see this double hump sign. And so on gonioscopy, you have kind of your first hump, this big valley, and then goes up again as you approach kind of our angle anatomy, ciliary body, scleral spur, and trabecular meshwork. And so this is due to large or anteriorly displaced ciliary body processes and is going to lead to a primary angle closure, but it's only really peripheral at the angle. More commonly hyperopes than myopes. Remember, our patient is myopic. These are the UBM photos here, and I think shows it really nicely. So iris bombay, whole iris is coming forward. Plateau iris, it's just the peripheral iris that gets pushed forward, but you can see if you look towards the cornea, in both of these images, it's a narrow angle here. How do we treat iris bombé and plateau iris? In both scenarios, a laser peripheral iridotomy is going to be the treatment of choice in many cases. And so this is a paper that's published in Ophthalmology titled The Comparison of New Visual Disturbances After Superior versus Nasal or Temporal LPI. They're trying to answer the question, is LPI safe for these patients who have iris bombé or plateau iris? And then second, is the amount of dysphotopsias, unwanted visual phenomenon, glare, halo, starburst, more based on a superior versus a nasal or temporal LPI? And what they found is at the bottom, iris bombé and plateau iris respond well to prophylactic LPI. It's safe for our patients, and there was no difference in the amount of dysphotopsias, whether it was a superior or a nasal or temporal LPI. And so back to our patient, we have a 57-year-old. We have trace NS in this patient. And so we did a clear lens exchange rather than an LPI in that patient. Let's look at another case, and we're on to some of our less common forms of acute glaucoma. We're looking at secondary angle closures. Now, this is a 59-year-old white female referred in to make sure it's not angle closure for this patient. IOP of 45 in the right eye, 13 in the left, visual acuity modestly reduced in that right eye down to 20/25. Gonioscopy is open to ciliary body. There's no NVA and no NVI in either eye. If you look at the slit lamp photo to the left, conjunctiva looks pretty white and quiet to me, but you can see these large KP on the backside of the cornea here, these big splat on KP, and this patient had anterior chamber inflammation. And so on slit lamp exam, this patient has uveitis and resulting uveitic glaucoma. With uveitis, I think there's two common clinical scenarios that you're going to see in practice. On the left, you can have a very hot eye. And so this patient comes in, they have a lot of light sensitivity. The eye is red. We have an anterior chamber reaction and a low moving to high IOP. And I always like to pause and explain this more because this was a confusing point for me in school and in residency. Why is it low moving to high IOP? But remember, when the uveitis hits, the ciliary body becomes sickened. We have a decrease in aqueous production. And then over time, we're going to give the ciliary body chicken noodle soup. Aqueous production ramps back up. But now we have a blocked aqueous outflow pathway due to all the inflammation. And so low moving to high IOP. Or in uveitis, you can have a quiet eye. So a patient who doesn't have a lot of conjunctival hyperemia, they're not light sensitive. They come in with a pressure of 45. They have an anterior chamber reaction and a chronically high IOP. Chronic iridocyclitis is a chronically blocked aqueous outflow pathway leading to chronically high IOP. What's the mechanism of action for high IOP in uveitic glaucoma? It's severe inflammation leads to the breakdown of the blood aqueous barrier. And so IOP elevation in uveitic glaucoma is really one of three common mechanisms. First, we can have an open angle uveitic glaucoma where fibrin cells, inflammatory cells, proteins clog up the trabecular meshwork. You have all this inflammatory junk, and that causes the eye pressure to go up because the trabecular meshwork or the angle is stressed and clogged. Number two, you can have a pupillary block angle closure glaucoma due to uveitis, because remember, with uveitis, the structures of the eye become inflamed and sticky, and so the iris sticks back on to the lens and we get pupillary block. Or you can have a non-pupillary block, secondary angle closure glaucoma due to uveitis because of peripheral anterior synechia, so the iris rolls up on top of or over the trabecular meshwork. How do we treat uveitic glaucoma? Here's kind of your 4 steps. Number 1, get rid of the inflammation the best that you can. We want to aggressively reduce the inflammation. And so in my practice, it's going to be difluprednate, predacetate every hour, every 2 hours. We'll occasionally use oral steroids like a Medrol dose pack, but we want to get the inflammation down, help the trabecular meshwork work again. Number 2, cycloplegia for 2 reasons. Number 1, comfort. Your patient's going to like you better. And then number 2, to prevent synechia. We said that as the eye becomes very inflamed, everything starts to stick together. If I'm trying to prevent synechia, I want to use cyclopentolate twice a day. I'll use homatropine 1% once a day. If you like to use atropine, you don't have to dose it every day for the prevention of synechia. Remember, if you're going to try to break synechiae, you want to use 10% phenylephrine. The medical treatment of uveitic glaucoma, I prefer aqueous suppressants over prostaglandin analogs. PGAs do have that risk of being pro-inflammatory, can get more CME with these, but really in this patient here, it's because aqueous suppressants just work faster. And I want to get the pressure down quickly, and so aqueous suppressants over PGAs. And then the surgical treatment of uveitic glaucoma. Step number one, we want to break the synechiae. So we can sometimes do this with YAG laser. More commonly in our practice in the ASC, the surgeon will go in with a kind of cutting device, cut out the synechiae. If that doesn't work, we're going on to a drainage implant. In our practice, we prefer tubes over trabs in the patient with uveitic glaucoma because there's so much inflammation, things are just going to scar down quickly. Let's compare and contrast uveitic glaucoma to glaucoma cyclitic crisis or Posner-Schlossman syndrome. So Posner-Schlossman syndrome, this is a unilateral acute trabeculitis. So this patient comes in, they have an eye pressure of 40 to 65. They're not overly light sensitive because it's a mostly quiet eye. There's minimal anterior chamber cell. And then two key differentiators for glaucoma cyclitic crisis compared to uveitic glaucoma. If you look very closely just to the right of that slit lamp beam, there's these very small stellate or star-like KP, and there's no anterior or posterior synechiae. Remember, mostly quiet eye. Glaucoma cyclitic crisis or Posner-Schlossman syndrome, this is a diagnosis of exclusion, and so rule everything out first. Posner-Schlossman syndrome is pretty rare. I've maybe seen 5 in my 12-year career, but if you do have a Posner-Schlossman syndrome patient, how are you going to treat them? Are you going to use glaucoma drops only, glaucoma drops plus steroid, steroid only, or refer for glaucoma surgery? And so in my practice here, we're going to use glaucoma drops and steroid. Answer B. But the book would say, and many of my mentors who I respect a ton in glaucoma would say, you can use steroid only in the glaucoma cyclitic crisis patient. If you're able to clear the trabeculitis, get the TM working again, the eye pressure will come down on its own. But I just have a hard time not putting a topical aqueous suppressant on the patient who has an eye pressure of 40 to 65. And then exhale, take a relaxing breath here, because even if you're misdiagnosing Posner-Schlossman syndrome as uveitic glaucoma, step 1 and 2 are the same. Get steroid on the eye, lower the IOP. We're usually going to start with aqueous suppressants. The initial treatment is the same. Another secondary angle closure glaucoma is neovascular glaucoma. Neovascular glaucoma results due to ischemia or lack of blood flow. Remember, blood brings oxygen. So ischemia to the iris, angle, optic nerve, head, or retina. A common trait of almost all neovascular glaucoma is retinal ischemia. We have a lack of oxygen to the retina. That's going to lead to neovascularization. We have these unhealthy and leaky blood vessels that start to leak blood. And then we can get angle closure glaucoma due to fibrovascular tissue, neovascles, and inflammatory cells. With neovascular glaucoma, again, 2 common scenarios. If you have a patient who's in the acute phase of neovascular glaucoma, this just happened, they're going to come in, they have a painful eye, they lost vision in the last week or 2, they have corneal edema, the eye pressure is over 40. I see a lot of patients who have old neovascular glaucoma that's chronic. They say, doc, I lost vision in my left eye 10 years ago. It's not painful. My pressure is 56, and they have minimal vision. According to the text, Glaucoma Science and Practice, central retinal vein occlusion, CRVO, and proliferative diabetic retinopathy, PDR, account for 2/3 of all neovascular glaucoma cases in the US. But really anything that causes retinal ischemia can be your culprit for NVG. And so ocular ischemic syndrome, central retinal artery occlusion, there's others that can lead to NVG. Treatment of neovascular glaucoma is tough. This is usually what we call a refractory glaucoma, meaning it's not amenable to the first-line treatment, which is often surgery. And so very difficult to treat. I will kind of break these patients up into 2 buckets. First, if I have a patient with meaningful best-corrected visual acuity in this eye with neovascular glaucoma, or they are mostly monocular, by all means, we have to lower the IOP. It's usually going to be an incisional glaucoma surgery. But if I have a patient with a good seeing contralateral eye, it doesn't have a lot of ocular pathology, their hand motion, light perception, no light perception, sometimes we will opt for comfort control. Keep that eye comfortable, but we're not going into a big glaucoma surgery because tubes and traps can take away everything all at once. In our practice, if we're going to go into glaucoma surgery in an NVG patient, again, we prefer tubes over trabs. And so this is a patient who is 1 day post-op Ahmed tube shunt. That's at 2 o'clock there. You can see some heme over the bleb and the tube at about 2 o'clock. And so next, let's look at surgically induced high IOP because of viscoelastics, gases that we're putting into the eye, hyphema, or steroid-induced IOP spikes. And so first, viscoelastics, why do we use them? These are thick gel-like materials in surgery. They help hold the anterior chamber open, they hold the iris back, and they protect the cornea and endothelium. Retained viscoelastic is the #1 cause for elevated IOP after uncomplicated cataract surgery. This gel material just clogs up the drain. And then the treatment is you can egress or burp a wound, kind of take out some of the aqueous or this viscoelastic material and or put on topical aqueous suppressants here. A big key though is if you have a patient with uncomplicated cataract surgery that now has a high IOP, and it's in the first 48 hours, that's most likely retained viscoelastic material. But if it's on day 7, the viscoelastic is probably out of the eye, and now you're thinking more steroid-induced. And so I said one of the treatment options is burping a paracentesis. Here's a video of that procedure. This eye's already been anesthetized. I'm going to kind of locate my 2 incisions. So you'll have your main wound and your paracentesis. I like to work through the paracentesis. We'll kind of loosen the epithelium and then push on the back wall of the incision. You see some fluid come out there. Couple keys. I'm going to aim to lower the IOP 50 to 65%. I don't want to take a patient from 50 down to 8. I worry about some effusions and the eye kind of collapsing too quickly. I'm going to check a Seidel sign here. And then remember, we want to put an aqueous suppressant on board because the ciliary body makes fluid or pressure at about 2 millimeters of mercury per minute. And so if I take a patient from 50 down to 25, 15 minutes later, they're right back up at that same spot if I don't put some aqueous suppressants on board. So even if you're burping a wound, you still want to put aqueous suppressants on board. What about post-surgery hyphema and traumatic? Hyphema is the mechanism of action here as blood occludes the conventional outflow pathway. And so blood blocks fluid going through the trabecular meshwork Schlemm's canal and the collector channels. If this is in the perioperative period, especially after a MIGS procedure, time is our friend here. These pictures on the bottom from left to right is about a 10-day period of a patient who had a MIGS procedure in our practice. Of course, the visual acuity is decreased in picture 1 and 2. It's really not in picture 3. I'm going to cycloplege these patients, make sure I have the IOP under control. I'll sometimes ask them to sleep elevated, and mostly I'm telling them, hey, if you don't sleep elevated, it's not going to change the healing. You're just going to take more time in the morning to get to cleared vision because as they're elevated, the gravity is going to bring that blood down. On the bottom, a traumatic hyphema, much different. We got to check the ocular integrity. We're going to do gonioscopy. What is the status of the lens, the iris, the anterior chamber? Do we have a cyclodialysis cleft? If it's a traumatic hyphema, then I want a bunch of steroid on board, all topical glaucoma drops on board. Hyphema, there's really 2 main sequelae in hyphema cases. Increased IOP can damage the optic nerve, and then you can get corneal blood staining. If you get that corneal blood staining, can lead to decreased vision long term. How common is a hyphema leading to a secondary angle closure glaucoma? Approximately 30% of patients with a traumatic hyphema will have elevated IOP, and the prevalence of elevated IOP really is correlated to the amount of hyphema in the anterior chamber. And so you're going to see an increased IOP in 10% of eyes if they have less than 50% hyphema, 25% of eyes will have an increased IOP if the hyphema is 50% or more of the anterior chamber. And then 50% of patients will have elevated IOP if it is a complete 100% hyphema. Malignant glaucoma or aqueous misdirection. This is shallowing of the central or peripheral anterior chamber angle. We have anatomical obstruction of the aqueous flow at the hyaloid zonule ciliary process interface, which leads to misdirection of aqueous. And so rather than aqueous wanting to go from the posterior segment into the anterior segment, it's basically reversing flow here. Etiology is unknown. We commonly will see this after intraocular surgery due to an imbalance of the pressure in the anterior chamber and the posterior chamber. And so these patients more common, this is a rare condition, but more common in things like a penetrating keratoplasty, not as common in things like a tube or trab, but you can see it. And this is a diagnosis of exclusion. We must be post laser peripheral iridotomy to diagnose a patient with aqueous misdirection. The treatment is often a second LPI, cycloplegics and aqueous suppressants. Here, a lot of these patients are going on to incisional glaucoma surgery. Steroid response and steroid response glaucoma. The mechanism of the disease here is steroids over time deposit and clog up the trabecular meshwork, leading to an IOP spike. Steroids over time deposit and clog the trabecular meshwork that causes a deposition of glycosaminoglycans in an extracellular matrix. So you have extra junk in the trabecular meshwork, and then you can have a loss of phagocytic activity. So you have more garbage, less garbage collectors to come and clean it up, and you have an IOP spike. 15 to 30% of the general population is a steroid responder. It's a higher incidence of steroid response and steroid response glaucoma in patients who have pre-existing glaucoma and patients who are more myopic or have a longer axial length. The incidence and severity of a steroid-induced glaucoma situation matters on the type of steroid that a patient's on. Most commonly, most severe with intravitreal steroids, followed by oral steroids, followed by topical steroids. The treatment for steroid response and steroid response glaucoma is really to get the steroid off the eye. 10 to 21 days later, the eye pressure hopefully comes back to baseline or pre-steroid levels. If it's not, and we need to go into surgery, I try to avoid the area that the tissue is damaged or clogged. And so we said that this is the steroids clogging the trabecular meshwork. And so we're going to avoid that with things like on the far left, a suprachoroidal stent, on the top right, Zengel stent, a subconjunctival stent, on the bottom right, an Ahmed tube shunt. Most of my patients with steroid response and steroid response glaucoma can be managed with topical glaucoma drops. How about drug-induced glaucoma and IOP spikes leading to angle closure glaucoma? How many office calls does your staff take of, I read this medication that I just started could cause glaucoma? This is gold for Thanksgiving fodder with your great uncle wanting to go through his medication list to see if any of them could cause glaucoma because he knows that you're an eye doctor. And so really for open angle glaucoma and drug-induced IOP spikes, it's really steroids. Steroids is your big one to know there. And then all of these common glaucoma, all of these common medications will have glaucoma on the potential adverse events. And so things like amantadine, an anti-Parkinson's drug, antipsychotics, antidepressants like fluoxetine, some of our antihistamines, Benadryl would be a generation 1 antihistamine, but Zyrtec, Claritin, Allegra, generation 2 antihistamines are going to be labeled for the risk of glaucoma decongestants like Sudafed. The key here is all of these are labeled as a risk for glaucoma being angle closure glaucoma in a patient who has pre-existing risk for angle closure. Another important oral drug to know in the angle closure glaucoma space is topiramate or Topamax. This is on label for epileptic seizures. It's much more commonly used off label for personality disorders, migraines, and weight loss. And so this can lead to bilateral angle closure due to choroidal effusion and swelling. You get basically a congestion of the anterior chamber angle because the ciliary body rotates forward because the choroid is pushing forward. The lens is going to move anterior. It thickens. So these patients will have a big myopic shift, 4 to 5 diopters. The incidence of angle closure after starting Topamax can happen very quickly, sometimes after even the first dose. And so the summary here is if you have a younger patient with bilateral angle closure glaucoma and a big myopic shift, they come in and they also can't see, think Topamax. The treatment short-term glaucoma drops and how we normally treat angle closure glaucoma, but you really won't need a PI in most of these cases. Long-term, we got to get these patients off Topamax and go in a different direction here. And so here's a case published in Ophthalmology. This is a 57-year-old female. She had 2 days of headache and blurred vision. Started topiramate about 1 month ago. The IOP is in the mid-30s in picture A and B. It's both eyes. And picture A and B, this is what the anatomical angle looks like on OCT and what the choroid looks like on UBM or a B scan here. And so you can see that we have this fluid behind the choroid pushing forward. Topiramate was stopped. They added aqueous suppressants, cycloplegics. 1 month later, you see pictures C and D. And so in your mind, bilateral angle closure in a young patient with a myopic shift, think Topamax. And so we've covered a lot of material here, but let's oversimplify managing acute glaucomas. Number one, find the culprit. What's putting us into angle closure? Is this patient in pupillary block? Is it a new medication? Is it synechia? Step number two, treat the IOP. That's the acute phase. We want to get the eye pressure down. We can do that with topical glaucoma drops. We can do that with LPI. We can use oral things like acetazolamide. Step number three, once we're out of the angle closure attack, what's our long-term plan to save vision and visual field, make a surgical referral when needed, and then ultimately save vision and save visual field for these patients. And with that, guys, I want to say thank you. Thank you for tuning in for 2 hours here. You have 2 more hours coming with Dr. Jessica Steen, who's one of my good friends and will do a fantastic job as well. I do have my email here, so if questions come up that we don't get to, feel free to reach out.
Awesome. Thank you so much. That was a wonderful presentation. We have a few questions in the Q&A, and guys, feel free to add some more questions in the Q&A if you'd like to ask Dr. Eibach while we have him here. One of the questions was, this particular doctor said, last I heard about a year ago for the Voyager Direct SLT, it has a per click fee. Says it seemed like it was kind of like a relatively costly click fee. Do you know if that's still the same?
Yeah, so this question is pertaining to direct SLT, so the non-contact SLT, and the device. Yes, the device does have a click fee or a per use fee.
Okay, great. And then another question was, would you be able to go back to a slide that shows some of the angle views of gonio and just kind of walk us through the structures a little bit more slowly?
Yeah, I could, but I'm going to give you even a better resource. If you go to www.gonioscopy.org, the University of Iowa has a great website with videos, with pictures. It will walk you through different less common scenarios like plateau iris or iris Bombay. And so I could take you back to that slide. It'll be clunky because I'll have to reshare. So I would just go to gonioscopy.org. Did I lose you, Ariel? Maybe. I can see Jess is moving a little bit. Hey, Jess.
How you doing, Mitch? Great
Good.
discussion this morning.
Thank you.
Good.
Sorry about that, guys. Can you hear me okay?
Yep, I can hear you.
Okay, perfect. Okay, cool. Let me go back to the Q&A here. Looks like that's all the questions that we have for now.
Awesome. Well, thanks, guys. Have a great rest of your Sunday. Hopefully the weather is nice and you're doing something fun outside.
Awesome. Well, thank you so much for the wonderful presentation. That was fantastic. All right. Hello, Dr. Steen. How are you?
Good morning or good afternoon, depending on where you are. I'm great. Nice to join you.
Great. Well, we're glad you're here. I'm used to doing these in the evening, so we started off first thing in the morning, and I was like, "Good evening, everyone."
Happy Sunday, right?
Yes. Well, I think we could probably take like a 10-minute break where folks can get up, move around, stretch a little bit, and then we'll come back right at 1. I'll do your introductory slides and have you go right into it.
Wonderful. See you shortly.
We'll see you soon. All right, so just a quick reminder for that QR code that was showing earlier. If you missed that, then we will be sending a survey at the end of this event. And if you just fill out that survey, we'll make sure to give you the instructions on how to get that credit again. So let's go ahead and get started. All right. So we'll start our next 2 hours of glaucoma CE with Dr. Jessica Steen. So her topic tonight is going to be optimizing glaucoma care, managing the comorbidities. So Dr. Jessica Steen is an associate professor at Nova Southeastern University College of Optometry, where she serves as the director of the glaucoma service and as an attending optometric physician at the college's Eye Care Institute. Dr. Steen teaches the courses in glaucoma and ocular pharmacology at NSU and also serves as the primary care with emphasis in ocular disease residency coordinator. She graduated from the University of Waterloo School of Optometry and Vision Science and completed her residency in primary care with an emphasis in ocular disease at Nova Southeastern University. Her main clinical interests include glaucoma, retinal disease, neuro-ophthalmic disease with an emphasis in medical and surgical management. Dr. Steen's research interests are centered on artificial intelligence applications and management of glaucoma. She's a fellow of the American Academy of Optometry, a diplomate of the American Board of Optometry, member of the Optometric Glaucoma Society and the Association for Research in Vision and Ophthalmology, and is the past president of the Palm Beach County Optometric Association. Here are her financial disclosures, all of which have been mitigated. So one quick thing while you're pulling up those slides, Dr. Steen, for the audience is for those that registered early for this event, we will be having the drawing for the $50 Amazon gift card. So I will announce that winner at the conclusion of the event. So stay tuned for that. And then we'll also display the Q&R code at the end for this 2 hours of CE. So please be sure to attend for that minimum of 100 minutes. And then similarly as before, just make sure to put your questions in the Q&A so we can go through them at the end. So
Wonderful. Now, are my slides up? Can you see them?
Yes, they look perfect.
Fabulous. Thank you, Dr. Sorenzi. Thanks, everybody, for joining. Sunday in the springtime, hopefully, again, just as Mitch said, lovely weather where you are. I'm in Fort Lauderdale, Florida, and it's kind of a dreary day today. We've earned it. I practice at Nova Southeastern University, and, we're really going to take things into, yes, discussing glaucoma management, but also really that clinical curiosity. What happens when you find something unexpected? How do you manage or co-manage that patient's retinal pathology, anterior segment disease, systemic disease? I love how Mitch spoke about Posner-Schlossman this morning. Something that I just had this past week, a Posner-Schlossman patient from many years ago who had been absent from my clinical care for the last 6 years. Now, usually when a patient's lost to follow-up, we say, uh-oh, that's not a great thing. In this patient's case, he has not had a recurrence since that period of time. He's now in his early 70s. So we think about that autoimmune dysfunction, maybe response to an infectious stressor, whether that's cytomegalovirus or another viral family. And, as we see patients often get older, in this particular patient's case, yes, he does have glaucomatous optic neuropathy in only one eye. He is not on medication. But thankfully, again, without a recurrence, without an elevation in intraocular pressure, he's been inherently stable. So sometimes that loss to follow-up, I'll say the only time in the next hour and 37 minutes or so, that's going to be a positive finding. Often, let's be real, many of these cases, when we're talking especially about managing comorbidities, there are significant demands on that patient for multiple specialty evaluations and care. The cost, the access, the time burden, the burnout, physician burnout, I should say not our burnout, but the patient's clinic burnout really can be significant when we're managing these complex cases. Any questions that come up, please do put them in the Q&A. I can't see them as we're going through now, but I'd be more than happy to chat at the end of our discussion. My financial disclosures, once again, are here. What is important is that all relevant relationships have been carefully mitigated. Now, before we really dig in, I do want to share this young case. This is an interesting case. This patient was referred to me due to a professional relationship that's been developed by his primary care doctor. Now, this primary care doctor works in an environment where generally these are patients who are not only lower income, but have significant overall social challenges. This is really a community healthcare system. Referrals are challenging out of the system. And this primary care doc called me and said, look, I've got this case. He just came back to me. He's young. And, I'm not really sure what's happening. He had seen another eye care provider. This happened to be about 3 months prior when his symptoms worsened. This was not an optometrist. That other provider had found no ophthalmic pathology, had, provided the patient with, artificial tears for a little bit of irritation that he had. But the primary care doctor, this just didn't sit well with her. She had said, what, would you please take a look? I know that you see a lot of glaucoma, neuroophthalmic disease. It sounds like neuro, but before I get this patient neuroimaged, I'd love for you to take a look at him. So 34-year-old healthy young man. And in his case, he had significant headache. And he had said left-sided vision loss. Now, was this only in the left eye? He thought so, but he said maybe it's also on the right, in the right eye on the left side of my vision. It's been going on for at least 9 months, but it has been worsening. He's 20/20. There is no afferent pupillary defect. His extraocular motilities are full. And you know what? Just as I'm speaking to him in the room, just getting this overall history, I do pick up a bottle of tropicamide and ask him against my white coat, does one eye feel a little bit brighter than the other? He said, maybe it's a little redder with his left eye. Okay, not what I'm expecting. So what do? I start with a visual field in this patient. And foveal threshold sensitivity, a really valuable marker when we're looking at concern for neuroophthalmic disease and therefore also the concern in glaucoma. This should be excellent. This should match the patient's entering acuity. 37 decibels right and left eye, symmetric between the two eyes. This is a positive, correlates with his excellent 20/20 acuity. And we can clearly see in the left eye, there is significant temporal field loss. Now, it does cross that vertical meridian if you're careful to look at the pattern deviation and the grayscale. But is there also maybe some left-sided vision loss on the right, in the right eye? Now, I take a look behind the slit lamp at the optic nerves, and the right optic nerve is crowded. We're looking at the retinal nerve fibrillary analysis here. There's a tiny little pinpoint cup. When I take a look at the left optic nerve behind the slit lamp, this is just undilated. This is just me taking a peek to get an idea of what may be happening. And, the nasal aspect of that left optic nerve was elevated. Superior looked elevated as well. Was it frankly swollen? This is where, put him behind the OCT. Let's see what's happening with the retinal nerve fibrillary. And we see the right, but the left, we're getting this significant error. The ganglion cell complex is well within a normative range on the right and left side. And I will tell you, I was the one who did this scan, and this is what I ultimately saw leading to this additional image. So what's happening? There's a retinal detachment nasal to the optic nerve. Why did the optic nerve appear elevated? It's not the optic nerve, it's the entire retina that's elevated. All right, so there's a nasal retinal detachment in this patient's left eye. Is this optic nerve dysfunction? It's not. If we take a look at the wide field image, this is very subtle. This is really subtle. If you're looking in the inferior arcade, you can see this boundary. In the superior arcade, look carefully. There's another boundary. There was a retinal break superior nasal, and if you really compare the retina nasal versus temporal, there's just a different appearance. Those vessels are, different appearance than they are temporal. Of course, this is now through a dilated pupil. With fundus autofluorescence, sometimes these detachments or chronic detachments can be a little bit more apparent. Look how lucky this gentleman is. You see it and you say it. Remember, he's 20/20. His macula is attached. his entire nasal retina, extending into the superior arcade, extending into the inferior arcade, is detached. He had a pars plana vitrectomy. It hadn't ended up, despite being macula on, considering the hoops that needed to be jumped through by the medical care system in his case. He had a pars plana vitrectomy about 5 days after presentation. He's been doing very well, thank goodness. Don't make your findings fit your diagnosis. This seemed like neuroophthalmic disease. She was ready to order an MRI, wanted one more look. It's the retina. It's not the optic nerve in this patient's case. All right, so let's dig into actual optic neuropathy. Let's talk about glaucoma management. We know that glaucoma is syndromic, that's described by this progressive ganglion cell axonal loss that drives characteristic retinal nerve fiber layer and ganglion cell loss on imaging and functional damage. Now, glaucoma is related to intraocular pressure, but at least, and we see this, of course, at least 30% of individuals with primary open-angle glaucoma have statistically normal pressure. Now, does that mean that their pressure's actually spiking outside of office hours? What's the role of home-based tonometry in establishing that true peak untreated intraocular pressure? I'll say with improved access of home tonometry, there is still a cost for the patient involved, but it's something that I'm not certainly using on every patient, but I am using more frequently. If I can get a true untreated peak intraocular pressure at the time of diagnosis, that really gives us a better understanding of what our target pressure may be and ultimately what our goal is in management. So let's talk about intraocular pressure as understanding that it still is the most significant risk factor for disease development and disease progression overall. But just because intraocular pressure is statistically abnormal, over 21 millimeters mercury, it doesn't mean that that's physiologically abnormal. And by the same token, just because someone has statistically normal intraocular pressure, let's say 17 millimeters mercury, that doesn't mean that it's physiologically normal for that eye. That is our primary open-angle glaucoma patient with, I'll say, statistically normal intraocular pressure. Now, for that reason, IOP is not a screening test to differentiate people with and without glaucoma. It is a screening test to identify an additional, very important, risk factor for disease. So where does our suspicion of glaucoma really come from in a comprehensive eye examination? That's from assessment of the optic nerve after we've assessed that patient's risk factors, plural. We'll talk more about risk factors. So, what about intraocular pressure? Our patients ask us all the time, Doc, what's my eye pressure today? Well, it's 15 in the right and 17 in the left. Well, is that normal? Well, how do we compare? What do we say when we tell our patients that the normal range is generally between about 10 and 21 millimeters mercury? Where does that come from? How do we know that that is what we'll say, quote unquote, as normal? Here is the real basis for that foundation. This is a publication from 1966, 1873 male left eyes. Now, this was a study that was conducted in Wales. So presumptively, all of these patients are English and of Welsh background. And when we really look at this range, what was determined is that the average intraocular pressure was between 15 and 16 millimeters mercury. Take 2 standard deviations on either side. That gives us a range of 11 to 21 millimeters mercury. So just as when we're performing OCT of a patient and we're avoiding just thinking about the red, yellow, green, and we're really thinking, is the patient who I'm imaging well reflected in the reference or normative database of my OCT? Am I able to compare my patient to the patients where that reference database was established in? Just the same way, we should think about this with every test, every evaluation that we perform, including intraocular pressure. So, how many patients do you have that are white men from Wales over the age of 40? Really, honestly, when you think about this, it seems, kind of as a reality check. I've got 2 patients that I've seen in my career that would have made or would have met the inclusion criteria for this study. The other way that I think about this, and we're so careful, is how we evaluate clinical research and clinical data, new publications. How do we apply that data to real life and to our own practice? The first step is to ensure that our patient that we're thinking about would have met the inclusion criteria for that study. Was it patients like my patient that were enrolled in that study based on age, diagnosis, background, medication use, treatment, whatever it may be? That's really our first step from a bigger picture here. So once again, intraocular pressure, of course, is a significant risk factor, but how we define abnormal intraocular pressure really is much more individualized. Understanding that patients can have disease both with statistically normal intraocular pressure and, of course, with elevated intraocular pressure. So as we're evaluating a patient for the suspicion of glaucoma, this is really risk factor assessment, and we think about the growing number and important risk factors that we understand that have a tie to glaucoma development and progression. And this list continues to increase. And I think something kind of nuanced here is to break this down and say, if we think about genetics and glaucoma, is that a separate risk factor? The way that I would describe this is genetics have a direct influence on each one of these established risk factors for disease. So genetics and genetic evaluation, polygenic risk score, is really another way to describe maybe the totality of the patient's overall systemic risk profile. Now, there is a commercially available tool, not widely utilized, still some room to grow, but genetics in eye care, genetics in glaucoma risk, we're really lagging behind, never mind other areas in eye care, but certainly other areas of medicine, something to look forward to. Now, the other piece is when we start thinking about comorbidities and ophthalmic comorbidities. When we look at each of these risk factors, we can right away think about other ophthalmic pathology that is tied to many of these underlying glaucoma risk factors. So while we like to talk about it, especially in a continuing education environment, one disease process, different ways to diagnose, to manage that one disease process, let's think a little bit more this morning or afternoon, depending on where you are, and how we practice. Meaning that we're assessing that patient. We're assessing optic nerve health, corneal health, retinal health, systemic health. We're thinking about our patients top to bottom, which also means that as primary eye care providers, we do need to quarterback that patient's eye and systemic health from top to bottom, regardless of your specialty area. So let's think about in glaucoma, how often do we perform testing? I really think about this as, well, it depends how we may best be able to determine change, and best meaning most quickly, right? So that's not going to be a cookie cutter approach for everybody who is a glaucoma suspect or open angle with borderline findings. Now, pachymetry really is a one-time test. Pachymetry does not change central corneal thickness, does not change significantly over a patient's lifetime. However, if I have ultrasound pachymetry from maybe 2010, 2012, I will repeat the pachymetry utilizing a light-based technology. The reason why is that, again, this is not for us as OATS purists. Remember, OATS utilized ultrasound pachymetry. When I say light-based technology, generally, we're talking OCT. The reason why is that OCT often measures central corneal thickness as slightly, in most cases, less than ultrasound pachymetry. Why is that? Remember, you or your technician performing ultrasound pachymetry are holding that probe and eyeballing the center of the patient's cornea. We're aiming for the center. What happens if we're not perfectly in the anatomic center of the patient's cornea? Well, the cornea gets thicker as we move into the mid-periphery and periphery. So we are going to overestimate the central corneal thickness if we're not in the center. What happens if we're not holding the probe perfectly perpendicular? Once again, it's a longer sound path overestimation. Now, if I'm comparing ultrasound to light-based pachymetry in real life, sometimes that's 5 microns. Is that clinically significant to me? No, it's not. But other times, I will tell you that has been 20, 30, 40 microns, 30 microns, 40 microns thinner, that is a significant difference. That might be the difference of 540 microns to 500 microns. With that, I will say additional risk factor of 500 microns, might that change your risk assessment? So once again, just as a background piece, thinking about how we measure this information is also valuable. Gonioscopy, Mitch hit home on this, certainly must be performed for the diagnosis of glaucoma and does need to be repeated. Literature, again, preferred practice patterns every 1 to 2 years. I'll say in practice, I generally repeat gonioscopy every 2 years unless there is an unexpected intraocular pressure finding. Even for patients who have had cataract surgery, angle's still going to be wide open 5 years after cataract surgery. But with a glaucoma diagnosis, I do still perform gonio every 2 years. Again, maybe a patient is developing early exfoliative material and we don't have the natural lens to see that Zamboni-like pattern. Are we looking at the angle carefully? Or many of our glaucoma patients, thankfully, are having MIGS procedures at the time of cataract surgery. Periodically, making sure that those devices are where they were placed. They're in the correct position, or there's no PAS that has formed, is valuable in assessing the long-term efficacy of MIGS procedures. Visual field testing, we know we don't do enough fields, and there are many reasons as to why. And, from a practical perspective, it's been described that fields in glaucoma patients are performed 466 plus or minus another 2/3 of a year, 232 days. Ideally, we're clustering testing, especially at the time of diagnosis, with the attempt to determine who are those patients. You've diagnosed primary open-angle glaucoma. Now, what's that patient's trajectory going to look like? How do we predict who those patients are that have real risk of visual threatening disease versus those that maybe they'll be on a prostaglandin analog, maybe they'll have SLT only, then cataract surgery with MIGS and never a medication in their life? How do we differentiate those two types of progression patterns? Well, past progression is the most significant risk for future progression. So, meaning that if someone has advanced disease at the time of diagnosis, that's not a positive. But what about an early disease? Yes, we are diagnosing disease earlier, thankfully, for our patients. That also means at a younger age. That also means a longer period of time living with glaucoma. So that first 2-year period, that's how long it really takes for us to determine that patient's overall future trajectory. Ideally 6 fields in the first 2 years, which I do still try to perform. OCT, every year versus every 2 years, change is detected more rapidly. Actually in this study, what was determined is that an OCT every 6 months detected disease change more rapidly than every year. Again, this was OCT alone. I do not do OCTs every 6 months. We would certainly raise the question of medical necessity, never mind cost, billing, but true medical necessity, especially as we're evaluating other risk factors for change. Understanding that, yes, more testing often is better to detect change. However, can we adjust the frequency of testing at a single visit? What I mean by that is instead of saying, I'll perform an OCT every year on this patient, or a visual field every year on this patient, based on statistical methods. This is linear regression. Again, 1965 is when this particular publication was published, with the understanding that the same number of tests, when clustered in a shorter period of time at the onset, let's say clinically, of disease diagnosis, was able to detect progression more quickly than the same number of tests spaced out equally over time. Now, what this has led to is the conclusion that you see by a very bright group of docs that multiple measurements, OCT fields or both, should, as a strong word, be obtained during the same visit wherever possible, even if that means seeing that patient back in a longer period of time. Now, practicality here is a real consideration. Our bottleneck in clinic is at the OCT. Now, if I were to start performing 3 OCTs on of the retinal nerve fibrillary and macula of the right and left eye on every patient, what would that do to my patient flow, and actually in our large clinic to my colleagues' patient flow as well? So there are some barriers here, but understanding that clustering testing statistically does allow for earlier detection of change. I think the practicality, the billing perspective is something that, that comes a little bit later after the understanding of this is good data. Now, how do I apply it? And that's the challenge in clinical practice. I will tell you that I don't have a set period of time that I'll evaluate or order a visual field or OCT. It is truly patient dependent. On average, that may be every year for an OCT, that may be every year for a visual field. For someone with more advanced disease in which OCT is not that valuable because it has bottomed out already, that might mean a field every 6 months. So really these nuances are difficult to apply across wide populations. What makes glaucoma fun and challenging is the individualized nature. All right, let's talk about some cases. Here's a 76-year-old man. He has a glaucoma diagnosis, mild stage in the right. What does that mean by ICD-10 criteria? That means that this patient has retinal nerve fibrillary loss with a clean visual field. Moderate stage in the left eye, retinal nerve fibrillary loss and visual field loss, but that field loss is outside of the central 5 degrees and in one hemifield only. He's been doing really well on generic latanoprost in each eye. He's 20/20. This is a routine visit. Pressures are 18 and 20. 20 is a little bit higher for him at this visit. Not a drop everything concern. We're still more than a 30% reduction with peak untreated pressure in the low 30s with an average to slightly thick central cornea. Now, if we look at this gentleman's change, or in all honesty, almost lack thereof over time, this is the right eye. What we're looking at is the mean deviation since 2008 to present on the right side and the retinal nerve fibrillary thickness profile. Here's another way to, instead of here looking at individual scans, looking at overarching metrics. So mean deviation, overarching metric, retinal nerve fibrillary thickness profile, the Tisnett plot. You can easily change this to an Enston plot if that's what you prefer. This just shows in this case 3 OCT scans, 2016, 2023, and March of 2026. Where's the change? Superior temporal, but that change has not happened. So that change happened between 2016 and 2023. Overall, he's been very stable over time. Here's a nice example of the repeatability of retinal nerve fibrillary parameters. I'm comfortable with this right eye. Here's the left eye. Didn't do so great on the field in that last field. Realistically, he's probably scheduled, it's been now, realistically coming up on about a year. Realistically, this is someone who is due for another field. In this case, if we look at, again, there's no reference database. This is just comparing the patient to himself over this 10-year period. Superior temporal is pretty flat. This is realistically the area where he's had damage, but there's no significant change over time. Where do I need to be more cautious? Inferior temporal. There does seem to be a subtle reduction in retinal nerve fibrillary thickness, inferior temporal, the area that had less or has still less damage to the optic nerve than, for example, the superior temporal area. Let's look at his nerves. He's had cataract surgery in each eye, large area of parapapillary atrophy. We see there's no disc hemorrhage. There's an epiretinal membrane on the left and, a bit of an epiretinal membrane on the right with this kind of change in pigmentation. All right. So if we look at his most recent OCT, okay, so retinal nerve fibrillary right and left eye. This is the new software, the new reference database that looks a little bit different with what's been described as this candy cane type of pattern, being borderline but outside of a normative range. Now, he does have retinal nerve fibrillary damage on the left side, superior temporal, more than in the right. Again, where should I be really cautious for this gentleman? Is this potential change in the last 3 years, inferior temporal on the left side. Now, remember that your ganglion cell, in this case, interplexiform layer analysis, also gives us the overall macular scan. This comes from the macular cube where the data is derived from, and we see the single horizontal B scan in the right and left eye. Now, there's this little pocket of almost thickening. That doesn't follow what we expect in glaucomatous damage. And if we look at the OCT, is that artifact? Is there something that's there? Is this deep retina? Is this choroid? When we find something that doesn't look right, dig deeper, investigate. So here's his macular scan. This is just the data that I already have from gathering the ganglion cell interplexiform layer analysis. This is using a workflow platform that allows this interactive evaluation of the data that's derived just from that macular cube scan. Again, this is not a PDF printout. This is actually evaluating the data, which would either need to be done generally without a workflow platform on the device itself, which again does clog up your workflow. So as we're thinking about how we best evaluate data, utilizing workflow platforms, really 2026, I am certainly all in. So this is the overall macular cube, the thickness map. I'm interested in that area. Let's see what's going on in the B scan. This isn't the highest quality B scan because once again, this is just the macular cube. All right, so where's the pathology? Well, it's not the inner retina. The RPE is a little irregular. The ellipsoid zone is spotty or shaggy in that area, but where's the pathology? Look at the choroid. This gentleman has a relatively thick choroid, except for focally in that region where the choroid is very thin. So now let's look at this as a higher resolution scan. Now, let's start at the top and let's scroll through each B scan. Again, this is done in my office or in front of the patient. Aha, there's the pathology. This is at the level of the choroid in the right eye. And this gentleman otherwise has a fairly thick choroid. So the question really becomes, is there choroidal neovascularization? Is there something that needs additional management? OCT angiography, allows us once again to scroll through the superficial, the deep capillary plexus, and then where we are most interested to the choriocapillaris and to the choroid. Again, is there, because of this disruption of outer retina RPE, is there neovascularization at the level of the choroid? And the answer here is no. There's some shadowing and backscattering because of the RPE dysfunction. So what does this guy have? What is this? My favorite reminder for myself is always, yes, there's epiretinal membrane, is not what is it first. First question that as clinicians we ask ourselves is where is the pathology? That will help us to hone in, really reduce the differential diagnoses from 50 down to, in this case, this is a very characteristic pattern. Once we determine where is the pathology, this is not something in the choroid that's pushing up. This is a focal area of choroidal thinning with, again, RPE irregularity. And here in this higher resolution scan, we do still see some very mild ellipsoid zone disruption. This is focal choroidal excavation. This is the conforming type. Again, this nice smooth pattern. Most cases here are idiopathic. This is not something where there's active neovascularization. There is no treatment for this patient, but it's one more feature as we're carefully evaluating the potential for change of his glaucoma. The reminder for him, if you ever have a sudden change to your vision, especially if it's in that right eye, this is something, do not wait till you come back and see me same day. We always have a doctor who is on call. Why do I say that? Not because at this time there is any management that's necessary, but because of the outer blood retinal barrier, I'll say dysfunction, RPE and Brooks membrane damage, this patient is at a greater risk of choroidal neovascularization. If there's an early membrane, I certainly want to know about it. An early subtle change, this patient requires prompt treatment. So no treatment at this point, but one more thing that now we've evaluated and does need to be periodically monitored. All right, let's shift gears to something a lot more common. Not these incidental findings, but honestly, these expected findings. We understand that ocular surface disease is common in our older population across the board, but increasingly common in patients who have a glaucoma diagnosis, and further increased in patients who use preserved intraocular pressure lowering medications. This is, of course, something that matters to our treatment. And I really think about this as being directly tied to adherence. And I find that my patients are less comfortable in telling me how their eyes really feel when they have glaucoma and know that they utilize or need treatment versus maybe a primary care population or just someone in general who does not have glaucoma or require treatment. Why is that? My thought on that is, for many of my patients, I really do think that they feel that as long as my pressure is good, I am doing well. They don't think so much about how their eyes should feel or how they could feel. It's almost, I believe the thought that it's the cost of doing business, that, my eyes are supposed to hurt when I use medication, and that's not true. So I do find that unless I really genuinely ask, and I don't just ask, do you have redness, tearing, burning, or itching? I know I'm not going to get a full or honest answer. I really want to know about my patient's symptoms, not do you have dry eye disease, but overall, what type of symptom might that patient have? I find that's best addressed utilizing a validated questionnaire. My preference is the SPEED questionnaire. OSDI or other validated questionnaires are wonderful. To me, they're a little bit too onerous for a glaucoma service. I find that with a SPEED questionnaire, I can walk into the room. That is the one piece of information I really don't know when I come in to see the patient. I can very quickly add up, assess the patient's symptoms, talk to them, take a look at the eye and the surface, and talk about what I'm going to do to address their concerns. Now, at the same time, what happens if you look at that SPEED questionnaire and it's 0 or 1, meaning very low? Moderate dry eye disease symptoms, really around an 8 on a SPEED questionnaire. That's when I start to get, the question of we really should intervene now versus maybe let's think about this, maybe let's watch. 8 is I need to do something different. What happens if that SPEED score is 0 or 1 and you look at the cornea and you see significant meibomian gland inspissation? You can't express meibum. Significant corneal staining, conjunctival chalasis, maybe even staining with lissamine green and lid wiper epitheliopathy. But their score is a 0 or a 1. Is that someone who, maybe just isn't so comfortable in describing what they're feeling with the mindset of as long as my pressure's stable, I'm doing well? Or is that someone who has neurotrophic disease, which again does need to be addressed? So it's not a slam dunk if the cornea doesn't look so hot and the patient's asymptomatic. That's actually I need to investigate further. Now, the patient's probably had proparacaine in the eye already. So at the next visit, sensitivity testing is indicated. But keep that in mind. Just because their symptoms are minimal, it's not always a good thing. I feel that if a patient is more comfortable, if they don't have that negative reinforcement of burning or stinging every time they put their eye drop in their eye, I see that as negative reinforcement. If they don't have that, are they going to be more likely to utilize that medication? Is their adherence going to be better? If their adherence is better, let's think about their long-term disease management. All right, so medication options, what's new? We do have more preservative-free options in the United States than we ever have. There has been a new approval in the last, I'll say, few months. This is not a drug that's available yet, but be on the lookout for it in the next couple of months and into the fall. Bimatoprost gel, 0.01%. This is a preservative-free bimatoprost gel that is now FDA approved. Again, I haven't gotten my hands on it quite yet. It's not yet available, but I am looking forward to gaining, first of all, some experience with this medicine, but another preservative-free prostaglandin analog. So now we have 2 preservative-free prostaglandin analogs in the United States that I'll say are more run-of-the-mill. Yes, we still have tafluprost, so technically a third. There are still some patients who do really well on tafluprost. I do find that it's not commonly prescribed. I may have one patient who still utilizes tafluprost. All right, so let's look at this woman. She's 62. She has primary open-angle glaucoma with an extensive surgical glaucoma history. She had a trabeculectomy in each eye, and unfortunately, her trab failed in the left eye. So she is now on I'll say three bottles, four medicines, three bottles in the left eye only. She's taking latanoprostene Bunod, she's taking notarcetyl and dorzolamide timolol, all in the left eye only. No medications in the right eye. She has autoimmune dysfunction. She's got rheumatoid arthritis. She takes hydroxychloroquine, and she's been on it for about 4 years. And she also is on etanercept as an injectable subcutaneous agent. Visual acuity, best corrected is 20/25. Her pressure is 5 in the right, 11 in the left, with a very thin cornea. So is 5 too low? She has no clinical signs of hypotony, so no, 5 is excellent for her. 11 in the left on these four medicines, and her speed score is 21. That's significant. So, I think about this and say, has no one done this before? In the literature, what's the description about truly assessing symptoms related to anterior segment disease in glaucoma patients? The Oates study developed a questionnaire that they determined, or they called the Glaucoma Symptom Scale, 1998. When you really look at this glaucoma symptom scale, it's actually very similar to the current SPEED questionnaire on the right-hand side. Not just do you have, but how bothersome is it? And again, how frequently, what I like about the SPEED questionnaire is how frequently is it? Because a patient may have, how frequently is it experienced? Because a patient may have something that isn't that severe. But if it happens 5 times a day, that's meaningful as far as quality of life. Just by the same token that someone may not have something very frequently, but when they have that feeling, it's debilitating. That's severe. But severe may also be, maybe mild symptoms, but all the time, which can be just as devastating related to quality of life. That's also why I like the SPEED questionnaire. Here are her optic nerves. Remember, right eye pressure of 5, left eye is her more advanced eye with 4 medications with a pressure of 11. Look at this nice retinal nerve fibrillary defect, superior temporal in the right eye. In the left eye, she's got retinal nerve fibrillary remaining, but really when you look at the optic nerve and the neuroretinal rim, she is notched significantly superior temporal and inferiorly effectively to the rim. She's got advanced disease. Visual field, maybe the right eye isn't quite as bad or isn't quite as significant as what you would expect based on the optic nerve. Severe stage disease in this right eye with that dense superior arcuate scotoma and paracentral scotoma. Difficult field for her on that left eye. Here's her cornea. All right, remember, right eye is on the left-hand side of the screen, left eye is on the right-hand side of the screen. Significant speed score, 3 bottles of benzalkonium chloride preserved medications on the left eye only. That's this one. But she still has significant, look at this dense inferior corneal staining on the right side. She is not using any IOP lowering medication. She does use occasional preservative-free artificial tears. Looks like she's got just a little bit of a tissue scratch there from rubbing on the right side. And you can see where this irregularity superior, where her irregular conge is with the functioning trabeculectomy, a much more difficult procedure in her case on the right with significant iris damage and a little posterior synechiae as well. But bottom line, it is not only the benzalkonium chloride that causes this corneal staining and ocular surface disease, because if that were the case, then removing the medicines would cure the disease. Eye drops for glaucoma do not cause dry eye disease, but they certainly exacerbate it. They often exacerbate it to the state that someone who is asymptomatic may become symptomatic. So your previously asymptomatic patient comes back 6 months later on generic latanoprostene and says, you know what, my vision's been fluctuating a lot lately. I feel like at night, really my eyes are much more tired. No, they don't feel dry. But of course, that patient is describing symptoms of dry eye disease. It's not the drug that caused it. It's the drug that exacerbated what was previously there. So I do take a very careful look at the surface with the goal to not, of course, wait until someone's corneas look like this, but to treat early and fairly aggressively, even if they're asymptomatic, knowing that that person may need an intraocular pressure lowering medication. So I'm still treating the disease that's there, but they're minimally asymptomatic, knowing that this topical medication could otherwise exacerbate their treatment. All right, where we are in 2026, we have a number of outstanding options for patients. We're luckier than ever. Our patients are more fortunate than ever. Yes, access is a moving target. Understanding how patients get each medicine is a lot of extra work for us. But with that knowledge, working with your colleagues, often we can find the most appropriate medicine and ensure that the patient can get that medicine affordably and reliably. Now, the other thing here is the low hanging fruit is, of course, she's got underlying autoimmune dysfunction. So we know that this person, again, has inflammation systemically, which is going to increase or exacerbate her symptoms. So in this particular case, we have a number of options. For her, what we talked about was she was concerned about adding another eye drop. She had gotten really good at her routine, and the question was, would another eye drop twice a day in each eye or 4 times a day in each eye be something that just collapses that carefully built house of cards of her glaucoma therapy? Again, she'd been doing really, really well. So we talked about another route of administration. She said, absolutely. So this is someone who has been now utilizing varenicline nasal spray twice a day. Here is her 4 weeks later. Okay, so baseline, nothing. Occasional artificial tears, which we know she's not really using. 4 weeks later, varenicline only. We're not completely out of the woods. Yes, she has significant, remarkable improvement here. There is still a poorly wetting tear film. There's still significant conjunctival and corneal staining. And since this time, this patient has waxed and waned. Some visits, the cornea looks worse. Other visits, the cornea looks even better than this. But it's that understanding that improving the surface, really, again, I hate to say it, but really in an individualized way, determining what might be best for that particular patient. What's their mechanism of disease? And honestly, what's the route of administration that might make the most sense for the particular patient? And sometimes that route may not be the obvious route. Here are her visual fields, right and left eye. Okay. And, remember, she's taking hydroxychloroquine, 200 milligrams twice daily. She is under that 5 milligram per kilogram per day dosage. But when this is our starting point, how can we effectively monitor for development of toxicity? Well, really, what we'd all been trained to do is carefully look at the highest resolution scan. This happens to be a 21 line raster, right and left eye, at the area of the ellipsoid zone, especially again in that parafoveal area. That's most likely, not in all patients, but across all patients, an average of where there is most likely damage to develop. Again, scrolling through each scan, a 10-2 visual field historically. Of course, there has been an update to the guidelines, initially published in November, but really this spring has gained a lot more traction and clinical application. So what's new in Dr. Marmer's most recent update to monitoring for hydroxychloroquine retinal toxicity? Well, primary tests are OCT, spectral domain, OCT, again, watching carefully for early ellipsoid zone disruption or damage. The other primary test in 2025-2026 is fundus autofluorescence, preferably wider field fundus autofluorescence, knowing that not all patients follow the same pattern. Not everyone develops this parafoveal damage. Some people develop more of a paracentral damage, wider out from the center of the fovea. So we want to make sure that we're catching early disease. Visual fields have been, I'll say it, demoted to really a confirmatory test. So almost like a second line test. I think I see damage on the OCT. Maybe there's a little hyperreflectivity on fundus autofluorescence. Now I'll go to, I say the visual field, but which one? The newest guidelines, once again, bring into the understanding that not all patients follow the same pattern. And the 24-2C visual field, again, that is proprietary to one particular manufacturer. 24-2C seems to detect, again, early damage. This has been validated by a separate group. Either someone who has early parafoveal damage or that more paracentral damage in the central 20-ish degrees. So this is a significant change. Do keep in mind the existing risk factors, dosage greater than 5 milligrams per kilograms per day. Yes, do calculate this on everyone. If that patient is skinnier, do also keep in mind that a lot of people are losing weight at rapid rates or significant weight fairly recently. So maybe they were well within that 5 milligram per kilogram per day dosage, and someone's just lost 35 pounds. Thank goodness, that's wonderful. But do keep in mind that that may result in an overdosage of their hydroxychloroquine, increasing their risk of retinal toxicity. Now, the other things to keep in mind are kidney disease and existing tamoxifen use, additional concerns that increase the likelihood of retinal toxicity. So I want to share with you another case. This is a woman who does have primary open-angle glaucoma in her left eye, but what are we looking at here? Top line of images, this is the ganglion cell interplexiform layer of her right eye, bottom row of the left eye. Right eye's been stable. What's going on in this left side? If we look at that ganglion cell interplexiform layer, that is not a pattern that's consistent with glaucoma. She has primary open-angle glaucoma. Actually, pardon me, she has angle recession glaucoma in her left eye. The key feature, gonioscopy. That is true unilateral disease. But why is she developing this diffuse ganglion cell interplexiform layer loss? That is not consistent with glaucomatous progression. She has lupus, and she is on just over 5 milligrams per kilograms per day of hydroxychloroquine. She's been on hydroxychloroquine over about, I think it's been about 6 years for her. Now, we can look at this deviation plot in another way. This is changing. Yes, it's more dense superior, but this is not, again, a pattern that's consistent with glaucoma. Could this be related to hydroxychloroquine use? Here's another way to look at this. This is something that, hasn't gained a lot of traction, but something that's been described as rapid macular thinning in hydroxychloroquine toxicity. So in this case, what we're looking at is the ETDRS circles overlaid, meaning giving us macular thickness. Since 2023, her average thickness under that entire ETDRS area is 13 microns. Why is she having progressive superior and inferior retinal thinning? This appears to be what is considered rapid macular thinning. This is a precursor to traditional retinal toxicity that we would detect with visual field and the 21-liner high-resolution scan. So again, this is thought to be a very early sign of retinal toxicity that precedes fundus autofluorescence change, visual field change, or more typical markers of hydroxychloroquine toxicity. So how do we talk to her prescriber, her prescribing rheumatologist about this? This is a phone call. Called the rheumatologist and said, look, this is what this woman has. This is not standard hydroxychloroquine toxicity. Realistically, this precedes standard toxicity. So, what do you want to do, doc? And I bring it up that way, knowing that for individuals who have lupus, hydroxychloroquine is first-line therapy. It has been demonstrated over and over again, not just to be core to therapy, but the reason is why is it improves overall, or I should say, reduces all-cause mortality in individuals with lupus. It is true primary therapy. It's not so simple to take someone off of that therapy. What we know is that in rapid macular thinning, this is kind of this lead time that gives a little bit of wiggle room before potential complete discontinuation is necessary. Rheumatologist says, thank you for not just saying she has to stop it. I understand. I'm going to consider additional therapies to try to get her off. But in the meantime, we're going to go to 300 milligrams per day. So how do you do that when the tablets are 200 milligrams? She takes 2 tablets one day, 1 tablet the next day, 2 tablets one day, 1 tablet the next day. She is being much more closely monitored. This is someone who I'm watching now for toxicity change every 3 months at this point, so more frequently, understanding that any further change, we might need to accelerate or the rheumatologist may need to accelerate her exploration of additional therapies. Rapid macular thinning, something to keep in mind. All right, 54-year-old female, lost to follow-up. since 2019. She has a history of primary open angle glaucoma, and she's been off treatment for nearly 5 years. She does have hypertension. She says that she does pretty well with her 2 medications that she takes. Her peak untreated intraocular pressure, again, she's been off of medicine for 4.5 years, is what I gathered on this day, which is 32 and 33 millimeters mercury. Central corneal thickness, thin, thicker average. This is very thin. So how do we interpret this? We can't play a conversion factor to the intraocular pressure, but we can say that realistically, I am underestimating her true intraocular pressure. Gonioscopy absolutely indicated here. It's been 4.5 years since she's been, or at least actually 5 years since she's been in the office. Angles are wide open, and it's not just is the angle open or closed, it's what else do we see? What's the level of posterior trabecular meshwork pigment? This is also valuable even early on, as we're thinking about who is a good candidate for SLT, or maybe who isn't the best candidate for SLT. Generally, younger patients with no pigment in the angle, not your ideal SLT patient. More pigment in the angle. Again, SLT is a pigment-dependent procedure. More pigment in the angle, realistically, an improved or better response to SLT. 2+ pigment, this is someone who would be a wonderful candidate for SLT. No peripheral anterior synechiae, no angle recession, and no neovascularization of the angle, and a beautiful flat iris approach. All right, here are her optic nerves in 2019. She's got a glaucoma diagnosis. There's no disc hemorrhage in either eye, but when you look carefully, there's a dense retinal nerve fibrillary defect inferior in the right. Maybe a defect here superior temporal in the right. Looks like 1 defect, 2 defects, 3 little individual defects superior temporal in the left eye. Why do we look at the nerve every single visit? It is not to describe a change or to find a change in cup to disc ratio. That's not going to happen. Let's be honest. Inter and intra observer variability are real. Why do we look at the nerve each visit? We're looking for a disc hemorrhage. So do document if there is or is not a disc hemorrhage. I do this at every single visit. That's truly why I'm looking at the nerve at every visit, which is generally every 3 months. Now, 2025, this is when she reestablished care. 2019, 2025. Go back and forth a couple of times. I've overlaid these reasonably well. We're looking at the retinal nerve fibrillary. There's no disc hemorrhage, but what is there? Well, jumping out on the left side, look at those new collateral vessels. And actually, jumping out on the right side, look at those new collateral vessels. So what's happened in the last nearly 6 years? Now, when I look at this patient behind the slit lamp, again, behind the slit lamp with your 90 diopter lens, it is very difficult to see retinal nerve fibrillary defect. But I am looking and scouring the superior arcade, and clinically what I see, it's tricky to see here, but there are these little vascular dilatations. So what are those extending through the superior arcade? I want to know more about the vasculature. OCT angiography will help me to image the fine capillary beds. Again, a motion contrast premise, meaning that only red blood cells are imaged. This is a map of moving red blood cells. In this case, in the overall, this is the overall retinal image. We're going to segment this out, superficial versus deep capillary plexus as well. But what do we find? Areas of capillary non-perfusion and just this irregular appearance to the capillary plexus. This is not the type of damage that happens to the capillary plexus, the superficial capillary plexus in glaucoma. This is not glaucomatous OCTA damage. This is vascular remodeling. Why is there vascular remodeling, especially in this deep capillary plexus? This is someone who had a retinal vascular occlusion at some point in the last 5 years. If we want to find where those collateral vessels are, they're actually very deep. You can see, again, we can segment out the area that we're interested in. Now we can find these capillary beds. Again, this is connecting vasculature directly into the choroidal vasculature to the retinal vasculature. So we're looking at a deep adjustment or disruption to capillary plexus. Once again, if we look around the optic nerve, here's this irregularity. This tells us that it's not just a branch retinal vein occlusion. Realistically, this is the entire superior hemifield that's been affected in this woman's eye. She has had an asymptomatic hemiretinal vein occlusion at some point in the last 5 years. All right, so what about the left eye? Pardon me, what about the right eye? Once again, these fine little capillary irregularities. She had bilateral hemiretinal vein occlusions at some point since we saw her last. So she has a diagnosis of systemic hypertension. She's apparently on top of her medication, but she has not seen her primary care physician in what she had said was close to a year, give or take. This is someone who needs to return to their primary care physician. This is someone who certainly we are sending a note to the primary care physician to ensure that really, in this case, a full physical examination is performed. She does have underlying risk factors. This is not something where I'm going digging for an answer, but I do want to make sure that a complete metabolic panel, complete blood count with platelets is performed, and this patient has complete medical care. Let's look at another difficult case. All right, these are all tricky because, again, we're not just managing one condition. We're managing patients who have glaucoma. This is someone with a glaucoma diagnosis, but what happens when you find something else that needs management? This might have just been a visit where it was just a 15-minute slot for a pressure check, medication check and pressure check, and sure enough, you find something new. Realistically, again, we're always looking for the unexpected and understanding that if the vision's not 20/20, we've got to explain why. If there's an unexpected finding, we have to provide an answer for it and to carefully ensure that we're addressing all of our patients' new concerns at every visit. That may not mean completely, but let's say someone reports new blurred vision in the left eye. And this is a visit where I have a field that's planned. Yes, I'll understand the history. Yes, I'll check the visual acuity. If it's determined that the vision's still 20/20 and that person's really just asking for a spectacle update, if I can do it on that day, great. Otherwise, I'll have that person, or if they're co-managed with another provider, I'm more than happy, of course, to have that patient return to their managing provider for evaluation of that concern. So really, one of our challenges in managing patients with complex and multiple ophthalmic comorbidities is to really prioritize and to say what needs to be addressed today and what can wait, which is a really valuable and important skill. 64-year-old woman, highly myopic in the right and left eye with overall good visual acuity. These are very difficult nerves to assess. This is someone who had a peak untreated pressure in the high 20s and has visual field loss. But assessing these optic nerves, looking for characteristic notching of the neuroretinal rim and finding retinal nerve fiber layer defect in these very thin choroid eyes is very challenging to do. She's on intraocular pressure lowering medication, had been determined to be within a target range. But what do we see when we look at the retina? Is this, again, myopic change that we expect in highly myopic eyes? This patchy chorioretinal atrophy extending towards the center of the fovea in the right, yes. And how about the left? Much more extensive with this patch of, if this is someone who had age-related macular degeneration, what would we call that? We would call that geographic atrophy. This is realistically one of my greatest concerns for our highly myopic patients. Yes, we worry about the peripheral retina. Yes, we worry about glaucoma risk. But long-term, what is there no treatment for? Myopic macular atrophy. This is something that can cause profound vision loss for which there is no cure, or treatment for that matter. While of course we do have early treatments for GA related to AMD, this is geographic atrophy, but not due to age-related macular degeneration. So the two existing complement inhibitors are not on label for someone with GA due to myopic macular degeneration. But how does this impact her glaucoma care? Here's an old field. Oh man, coming up on 10 years already. This is a 24-2 CETA standard in the right and left eye. And, if we think about her imaging, is OCT hopeless? In this case, you have to do it to determine whether it's valuable or not. She had not had OCT of the retinal nerve fiber layer or ganglion cell complex or interplexiform layer performed in many, many years. So I said, you know what, let me give it a try. Let's see, maybe there is some useful information here. All right, so I'll actually say in the right eye, I think this is useful information. What I'm pointing to is the inferior temporal blue arrow, this retinal nerve fiber layer defect in the right eye. That to me is valuable information. That's actually a better scan, and the device did a better job of segmentation than what we probably all expected. This is not something I'm repeating annually on this patient because I think the utility is very limited. I think visual fields are a much better evaluator of potential change over time. But I really, before saying that an OCT is useless in this highly myopic eye, I wanted to actually see it for myself. In the left eye, the retinal nerve fiber layer, very little, I'll say, helpful or useful information. The device had a much harder time in segmenting the data, and I had a much more difficult time imaging her. We see this image reversal. Look where the nerve actually is in here, and look at where the device tried to find the anatomical landmarks. Didn't do a great job. Sometimes in highly myopic eyes, the ganglion cell data is more valuable. In this eye, what do we see? Well, I guess the superior ganglion cell interplexiform layer is fairly intact. Inferior and inferior temporal less intact. Does that correlate with the retinal nerve fiber layer defect? I mean, you see how I'm saying it, sort of, but look at the device having the challenge of segmenting the ganglion cell and interplexiform layer from the retinal nerve fiber layer and from the deeper retinal layers. It's challenging. I don't know if this is the most valuable piece. And in the left eye, again, more difficulty in imaging. But look at what is picked up already, even on this low contrast scan. This is all sclera. There is very little choroid here. This is the area of, again, macular atrophy. So let's look at this a little bit more. If I go back, this was as early as about 2010 on the left-hand side. Fundus photography, a technology that does not change. With all of our advanced technology and all of our tools that we utilize in glaucoma risk assessment and evaluation for change, I still perform standard fundus photography generally once a year, or of course more frequently if there's something new to photo document for future. Why standard fundus photography? Because it's a technique that doesn't change. Again, if I'm utilizing ultra wide field imaging, it's not true color. The nerve will always look a little bit pale. Pale nerves will look very similar to healthy nerves. I like a true color image. And again, I can compare this patient through the rest of her life utilizing this technology side by side. Look how her optic nerve has changed, number one, but look at how her retina has changed over about a 15-year period. This new development of myopic macular atrophy that's here, and this significant change in her parapapillary atrophy and this patchy choroidal atrophy. If we look at this in cross-section, her RPE is obliterated, so this is complete RPE and outer retinal loss, termed C-RORA from our retina colleagues. Again, this is not in context of AMD. This is myopic macular atrophy. Look how thin her choroid is, even subfoveally. But look at how this hyperreflectivity changes when we lose the outer retina and RPE. We see increased light that's passing directly through the sclera. And here's a little area with RPE, and then now to the left, we're in the area of parapapillary atrophy. Once again, no RPE. Where are we looking? Then what are we looking at? Why do I also worry about this? Well, choroidal neovascularization can develop, but we also know that this GA can grow and change over time. Thankfully, the center of her fovea is currently spared, but I worry about her. And what about the other eye? Some of you may have caught these subtle changes. Yes, the inner retinal and vitreoretinal interface anomaly with this early traction and cystoid space that's developed. But I will tell you from a vision perspective or potential vision perspective, I'm actually a little bit more concerned about this nasal to the center of the fovea area, this irregular RPE in outer retina. Again, if we have sick outer retinal boundary, outer blood retinal barrier, that means that any abnormal vasculature can more easily pass into the neurosensory retina. So we think about, again, myopic neovascularization, choroidal neovascularization. I actually worry a little bit more about these areas. So it's not just the eye with the atrophy, always carefully looking at both eyes. Her field has changed in the left eye. So then the question is, why? Is this progression of her glaucoma in the left eye, or is this the new or developing or changing macular atrophy? So if we look at this, she's had a stable intraocular pressure in the right and left eye. Her right eye has been stable over time, but her left continues to go downhill. Oof. Again, carefully look at the macula. I believe that this is not glaucomatous progression. I believe that this is only due to her macular pathology. But this is your eye. This is your patient's eye. What do? Do you do nothing and chalk it up to something that we can't control? Or do you do something? What is that something? Lowering the target pressure, which is what we've decided to do. I don't know if it will have a benefit for this patient. You know, this is really the concerning, unfortunate reality of myopic macular degeneration. We've adjusted her target pressure. Again, short term, she's been fairly stable, but I do worry about continued progression. So what is it about myopia and glaucoma? We understand that glaucoma risk increases with high myopia, and that is exponential when the patient, or when you or your patient hit that 6 and about 7 3/4 diopters mark. That becomes more significant. This is thought to be primarily due to mechanical stress. So when there is increased or high myopia, there is realistically in most of these patients a significant component of axial elongation, scleral expansion. What's the extension of the sclera posteriorly? That's the lamina cribrosa. So when the sclera stretches, the extension of the sclera, the lamina, stretches as well. Okay, so now what passes through the lamina are many, many, many axons. Those axons are supposed to be well insulated and supported by astrocytes that line the pores of the lamina cribrosa. But if that structure, if that skeleton, it's a living skeleton that's supposed to protect the axons, is pulling and stretching with the axons being sheared and stressed passing through it, stressed axons lead to axonal death. That is and can be a glaucomatous process. So the thought really here is, with significant axial elongation, that's what causes damage to the axons passing through the lamina cribrosa. Again, when you've got tilt or torsion of the optic disc, this can also increase laminar strain. And, you know, I put this last with a question mark. It is very difficult to diagnose glaucoma in these highly myopic eyes, considering the challenge in assessing the optic nerve. So again, if there's tilt and torsion, there can be visual field defect in retinal nerve fiber layer loss due to the structure, not necessarily as a progressive pathology like glaucoma. So differentiating these overlapping, I'll say even optic neuropathies, or causes of retinal nerve fiber layer and visual field damage are significant. So sometimes maybe is there an overdiagnosis? Do we tend to overdiagnose in these very difficult borderline cases with the goal of lowering the pressure to determine if there's a benefit? You know, maybe we do practically, clinically, and that very well may be an okay thing. All right, let's look at a couple more. 67-year-old female. She had been a glaucoma suspect. You see the dates here. We're going back many years. And then in 2015, something changed. So she had always had one eye that had higher eye pressure than the fellow eye. Sometimes we call this train track or railroad sign. You know, if somebody's consistently higher in one eye versus the other, realistically, this might be someone who is suspicious of developing disease in that higher intraocular pressure eye. There may be nothing to see at this point, but again, there is an inherent difference between these two eyes. But 2015, what actually changed? She developed a central retinal vein occlusion with macular edema and underwent multiple intravitreal injections. For a couple of years, she had bevacizumab. She also had the dexamethasone intravitreal implant a little bit later. So, how could intravitreal injections, let's talk about anti-VEGF injections first, lead to the potential for short and or long-term elevated intraocular pressure? Of course, she was medically managed, which is why her intraocular pressure has come back down and has stayed where it is. Now, we think about this long and short term consideration and the impact on the risk of development of open angle glaucoma, or for someone who has open angle glaucoma for disease progression. So, your primary open angle glaucoma patient who also has diabetic macular edema undergoes a series of anti-VEGF injections. Is that good for the optic nerve? It's great for the retina, but I will tell you, not great for the optic nerve. So what's the story here? Short term, if we think about intravitreal injections, realistically, we probably all talk or think about the greatest risk of intravitreal injection being endophthalmitis, depending on the resource that you utilize, generally one in about 2,600 injections. But immediately after an anti-VEGF injection, intraocular pressure has been described in a human to rise up to 87, I'll say spike, up to 87 millimeters mercury. Now, most patients, thankfully, do not have this intraocular pressure spike to 87. Most patients will increase about 20 to 35 millimeters mercury. That is not insignificant. And, the question that you might be thinking about is, does everybody know this? Do retinal surgeons know this? Do they measure this? I've never seen this recorded in a chart before. Most retinal surgeons do not measure intraocular pressure after intravitreal injections. Why not? Because we all know, including, of course, retina specialists know that IOP increases. It normalizes and returns back to baseline fairly quickly in most people, between about 10 and 30 minutes after the injection, most people. So how does this happen? Realistically, this is just increased volume in an enclosed space. The vitreous cavity volume, depending on the size of the eye, around 4 milliliters, and most intravitreal anti-VEGF injections are 0.05 milliliters. So this is why pressure increases. Caveat here, the high dose aflibercept molecule, the 8 milligram aflibercept molecule, is 0.7 milliliters. It's a more volume. And the 2 complement inhibitors are 0.1 milliliters. So again, double the volume of our standard anti-VEGF agents. So think about the potential increase in intraocular pressure short term in those eyes. There's a very recent publication with a group at the University of Western Ontario, very near to where I trained. And what they determined, I'll say this is not something new or profound, but I'm glad that there's ongoing discussion about this. There is, of course, transient intraocular pressure change, and that correlates with visual acuity. If the pressure's higher, immediately after the injection, the vision is more poor. Again, here we're talking on average, they use Logmore units. I had to convert this for myself, about 2,514. The vision's bad immediately after the injection, and it recovers quickly as the intraocular pressure lowers back to baseline. So here's, I think the important takeaways here. Look at the IOP range from about 10 to 18 millimeters mercury to immediately after the injection. They were up to about 75 millimeters mercury, and this was 1 minute after the injection. So this means that patient was really lucky that they got a nice washout of the antibacterial and antiviral agent that's utilized, the iodine product. Thankfully for those patients, if the intraocular pressure was measured immediately after the injection, not 60 seconds later, the IOP would have been even higher. All right, so bottom line, patients have poor vision immediately after the injection. That correlates with higher intraocular pressure. I'll tell you, as someone who receives anti-VEGF injections, not for a CRVO or diabetic retinopathy, thank goodness, but as someone who has chronic low-grade inflammation after a complex retinal detachment repair. I know how high approximately, I'll say as an experienced patient, I know approximately how high my intraocular pressure is based on how quickly my vision returns. If my vision returns back to close to baseline in a minute or two, I know my pressure is probably only about 30 or 35. I know if when the nurse comes back in after a nice washout or maybe about 5 minutes after the injection, if I'm still like basically hand motion, I know my pressure is about 50. Visual acuity correlates with intraocular pressure. Now, I don't tell patients this. I don't want them to overanalyze or to think too much about this, but important for us to know that IOP spikes after these injections. And of course, that can't be good. There is potential risk of retinal artery occlusion when there is this sudden spike, meaning that there is a pause in retinal perfusion. Ooh, that is another consideration. So what do we do? Topical intraocular pressure lowering medication, oral acetazolamide, it's not enough. If the pressure is 75, 87 millimeters mercury, a drop of iopidine or a couple drops, maybe the pressure will only be 65. Is that still clinically meaningful to you and I? Absolutely. What has been described as a more definitive approach to normalizing the intraocular pressure is an anterior chamber paracentesis immediately before or after the injection, removing the same amount of fluid that is going to be or has been injected into the eye. So 0.05 milliliters, 0.1 milliliters, for example. And in this particular 2019 evaluation, there were no additional cases of endophthalmitis or hypotony, thank goodness. But again, this is essentially described as like a fluid balance. If I'm putting in a certain amount, let's take out a certain amount. And that does immediately normalize the intraocular pressure. This is not widely performed by retina specialists. Why? Because there is increased risk. While in this study there were no additional adverse effects or events, it is another hole in the eye. There is another place by which there can be an infectious driver. So what about longer term? Like our patient who had this long-term intraocular pressure rise, these are actually the patients that we see in our office. Remember, that immediate spike, that's important for us to know, but we're not observing it. These are when the patients are in the retina specialist office. So what might we see? This longer term rise that realistically is all about aqueous outflow, reduction in trabecular outflow. There was some thought that maybe this was due to direct toxicity of the medication. Thank goodness it's not. There can be some low-grade inflammation, trabeculitis. Aha, this is the connection to this Posner-Schlossman syndrome, that trabeculitis, reduced trabecular outflow, very high intraocular pressure. This can happen with not Posner-Schlossman syndrome here, but this increased intraocular pressure after intravitreal injection can happen after intravitreal injection. There can be aggregation of particles in the TM, physically blocking the TM and reducing aqueous outflow. And there is an impact on nitric oxide dynamics. So silicone oil, we're talking medical grade silicone oil that lines all injection materials. This is a microscopic amount. However, if you are a patient who receives intravitreal injections every 6 to 8 weeks for 10 years, that microscopic amount per injection now becomes cumulative and can be meaningful in reducing trabecular outflow. The silicone oil can also be pro-inflammatory, driving a trabeculitis. This is not someone that you would see cells in the chamber in, but we're talking how can we describe why someone has this elevated intraocular pressure longer term. I think maybe the most interesting mechanism here is related to nitric oxide dynamics. I think Mitch talked about latanoprostene bunod, latanoprost acid, plus a molecule called butane diol mononitrate, which releases nitric oxide into the trabecular meshwork, increases the space between trabecular beams, and therefore increases trabecular outflow. Now, when we think about nitric oxide signaling overall, okay, actually let's back up and think about what happens in pathology. So if someone has neovascular let's say proliferative diabetic retinopathy, and they've had light PRP and they're receiving intravitreal anti-VEGF agents. So what has caused those new vessels? It's ischemic stress in the retina. There is more need for oxygen in the retinal tissue than what's being supplied because of such profound damage to the retinal vasculature. So what does the body do? The body tries to get more oxygen to its oxygen stressed tissues. And one of the ways that it does that is by trying to create new blood vessels. Unfortunately, most of those new blood vessels don't carry oxygen that efficiently. And that's why these are these leaky, irregular vessels. But this is the body's response. The demand is much higher than the supply. So how can we increase the supply to match the demand? Let's create new blood vessels. Now, it's not only a VEGF-driven process. There are many other markers, molecules, and signaling proteins that are involved in new vessel formation. One of them is nitric oxide synthase that is upregulated with anti-VEGF. Another way that the body's trying to get more blood to these stress tissues, let's increase nitric oxide in these stress tissues to cause some vasodilation to, again, get more oxygen to the ischemic tissue. Nitric oxide synthase leads to increased nitric oxide. Okay, so in ischemia, when VEGF increases, nitric oxide synthase increases. So what happens when an anti-VEGF is used? VEGF is downregulated, nitric oxide synthase is downregulated. So what's the impact on, for example, the trabecular outflow? If there is reduced nitric oxide in these eyes, could this be reduced trabecular outflow? Who's most at risk? Logically, if someone has more injections over their lifetime, if someone has more frequent injections, they're at a greater likelihood of long-term increased intraocular pressure. Interestingly, younger patients are more at risk versus older patients. This is related to scleral dynamics and scleral compliance. And of course, someone with a shorter or smaller eye means that 0.05 milliliter injection is a greater overall percentage of their vitreous cavity volume, greater eye pressure increase. Now, what about for someone who has had a pars plana vitrectomy, like the young gentleman that we looked at first, or this eye that has, again, if we look at what's filling the vitreous cavity, thankfully this is not vitritis, this is silicone oil that is microemulsifying with an attached inferior retina. Silicone oil in the eye, again, any eye after vitrectomy has the potential, yes, for short-term IOP spike while these patients are under the care of the excellent retina specialist, but long-term IOP rise, this is when they're under our care. Silicone oil has as great as a 40% risk of IOP elevation. Now, silicone oil is not meant to be permanent, but many patients will have oil in the eye for many years. These patients need intraocular pressure evaluated. Bottom line, for all patients, not just our pars plana vitrectomy patients, but yes, for patients who are undergoing intravitreal injections, whether those are anti-VEGF injections, complement inhibitors, or of course steroids that can increase intraocular pressure by a separate mechanism altogether, reducing phagocytosis, allowing for extracellular matrix to not be turned over, physically blocking the trabecular meshwork. These people all should have intraocular pressure measured in our offices and have that lower threshold for consideration or change or worsening progression of their glaucoma if they have a glaucoma diagnosis. Okay, now let's put things together. This woman's 55. She was referred for evaluation for glaucoma. This was, again, referred from a primary care physician. And her history, she had been diagnosed with glaucoma about 5 years before. She was lost to follow-up over about a 2-year period. And really what caused her to take better control of her systemic and eye health, first presenting to her primary care physician, was feeling that, you know what, I feel like my vision's changing. And she thought it was more in her right eye, but wasn't totally sure. She said things were just feeling a little bit more narrow. She has not used intraocular pressure lowering medication for 2 years. Remember, she's 55. She has had bilateral cataract surgery already and bilateral rhegmatogenous retinal detachment repair. Her best corrected acuity in the right is 20/80 and 20/25 in the left. Pressures, no medicine, 20 in the right, 28 in the left. So, new patient. This is where prioritization comes into play. We've got lots of things to look at. Does this person, I just pinholed her visual acuity. I'm not refracting her on this first problem-focused medical visit. Now, does she need a refraction? I'm sure she would benefit from a refraction. But what are our priorities? My first priority is the angle status, because if this woman's in angle closure, the management looks very different. Why is her vision reduced? I do want to account for that. Realistically, I'm not going to do a full refraction. I've pinholed her. I've taken a very careful look at that right side. Best corrected to me is 20/80. She has a history of rhegmatogenous retinal detachment, both eyes. What's her retina status? And then, all right, the pressure is 28 in the left eye. Yeah, we're going to lower the pressure. But that's not the emergency. Honestly, I see that at this visit as the least complex piece of this new patient evaluation with significant ophthalmic history. All right, so gonioscopically, let's look at the angle. It's wide open, thank goodness. Nice flat iris approach. She's got a sample SE line. She's fairly fair, but has quite a bit of pigment in the angle for being fair, 2+ posterior trabecular meshwork pigment. Okay, one thing out of the way. Now we move on. Why is her vision reduced? So the right eye is the 20/80 eye. There is epiretinal membrane. We can see that. The macula is a little shadowed here. These photos were taken as she was dilating. Look at her optic neuropathy. She is notched nearly to the rim, superior and inferior in the right eye. Could her vision be 20/80 due to glaucomatous optic neuropathy? It's possible, but let's be careful here. Left eye, she's notched superiorly to the rim, inferiorly notched. And again, these areas, again, she's had surgery in both eyes, but there's more, I'll say deep RPE disruption. Maybe was this someone who had previous intraocular inflammation on that left side? Here's her right macula. We're digging for a reason for 20/80 acuity. It's a beautiful clear view in. She's had a YAG capsulotomy. You see, she has also had a vitrectomy. Her vitreous is perfectly clear. So why with that intact ellipsoid zone and outer retina, why is she 20/80? She has not, what is it, but where is it? In the inner nuclear layer, she has these microcysts. These are not fluid filled in the sense that this is not cystoid macular edema. What you will see this in patients who have advanced optic neuropathy, whether it's glaucomatous optic neuropathy, whether it's Leber's hereditary optic neuropathy, any patient with advanced optic neuropathy can have these essential spaces in the inner nuclear layer where cell bodies should be, but are not. Looking at the macula, the reason why she's 20/80, it's not that little epiretinal membrane. It's not this little tiny irregularity in the foveal contour. It's because of her optic neuropathy. Okay, another understanding of this patient's picture evaluated. She has also had a scleral buckle with extensive cryo. Here's the retinotomy area. This was the area where subretinal fluid would have been drained intraoperatively. And how about this left eye? Carefully looking at the retina, it looks like she's actually had some laser in really the posterior pole. Difficult or more difficult image, but clinically, it doesn't appear well in the photograph. I look at the retina first. She's got not only lattice degeneration with holes, but she has subretinal fluid that has extended posterior to this area of lattice. She's got a new retinal detachment. Oh, this is about 2 or 3 disc diameters of fluid. Yes, it's inferior temporal, but her retina is not intact. Man. All right. So management of this patient's case. We're thinking about prioritization. This is someone who, yes, I started back on latanoprost and 1 drop each eye, but this is a same-day retina referral. This is someone with, yes, the macula's on. This is her only functioning eye. This is same day, and she was thankfully lasered. She's been stable now on 2 medicines, real monocular precautions. She has been connected to low vision services in consideration of her advanced optic neuropathy in both eyes. But I think the key here is that as we see one of these complex patients as a new patient, and we feel like there are so many pieces that I have to evaluate, where do I start? It's that prioritization. What questions do I have? What are the biggest concerns? Is there something that I could be overlooking? Why is the vision only 20/80? Accounting for that reduction in vision is really an important piece here too. All right, let's look at this case. We're doing great for time. She's 72 and had presented for a second opinion regarding reduced visual acuity. She splits her time between Michigan and South Florida. She is back up in Michigan for the summer. She has hypercholesterolemia and has primary open angle glaucoma and alternating esotropia, but thank goodness she has a really great optometrist and she is perfectly happy with her current single vision spectacles. Here's the other piece. When you are co-managing patients, ophthalmology and most importantly with one another, this is something to be really respectful and aware. We're all respectful, but to be very aware of what you as the consulting optometrist are being asked to evaluate. In this particular case, this was something that in Michigan, the doc, unfortunately for her, she just didn't understand why the vision wasn't as good as what she thought. The doc did a beautiful job. She just needed someone else to explain it to her. This is not a comprehensive patient of mine. This is not someone who I see for comprehensive care. I was asked to look at a specific reason. And in that case, I'm going to be very respectful and very aware of the care that the other providers, excellent providers, are providing for her. This is not stepping over someone. This is ensuring that patients are getting exactly what they need at every step of the way. When we talk about specialty care and consultative care, it really is something to be mindful of. So when someone like this, if she were to ask me, Dr. Steen, can't I just see you for my ongoing spectacle prescription and my double vision? The answer is no. She's got a fabulous optometrist. The optometrist is doing a great job. Absolutely not. That is not something I'm going to evaluate. And I am more than happy to tell the patient I will not. You are here with me for this one particular reason. Ask Dr. Smith for the ongoing care. See Dr. Smith for all of your other eye concerns. All right. She's got glaucoma. She's got a retinal nerve fibrillary defect, more so in the left than on the right, but she's also got macular drusen. She's 20/30 in both eyes. In this near infrared reflectance imaging, sometimes we see more or a greater extent of drusen than what we see, certainly, by color fundus photography. Look at the drusen superior temporal. Look at the area inferior. Again, this is an OCT-based image, that black and white near infrared reflectance-like image. If we look at a couple of cross sections through the right macula, again, there's vitreoretinal interface anomaly. There's retinal drusen in the right. And if we scroll through that area superior temporal, this is someone who has reticular pseudodrusen superior. Why does that matter to identify? This is someone whose risk profile for progression of AMD has now changed. She has an increased risk of progression to late-stage AMD, geographic atrophy, and neovascular disease. Left eye, very similar story, right down to the vitreoretinal interface anomaly. Other tools that we can utilize to really quantitatively evaluate retinal drusen and change over time. This happens to be an RPE elevation map. What this is showing is where the RPE is most elevated, accounting for the areas where there is drusen, pushing the RPE up. For patients who have geographic atrophy, this will also help you to map areas of GA. But really, what's the question? The question is this patient changing? And if so, how quickly? So if we look at her macular scans 2019 to 2024, this is the same cut. You can see that there's a significant increase in retinal drusen load, both in the right eye and the left eye, and that vitreoretinal interface anomaly has changed in both eyes also. So it's changed, but how quickly? This is where additional tools come into play, depending on the platform, once again, that you use, but I'm sharing this as this is one of the ways that we objectively monitor patients over time. How quickly is this person changing? What is the drusen load increase over time? In the right and left eye, it looks like there's some segmentation error here that dropped, but we can see that she'd been really overall stable 2018 to 2019, but since then it's been this gradual increase in drusen load. Also be cautious. Drusen load increases, and if someone becomes atrophic, if they are unfortunately developing geographic atrophy, that drusen volume, or I say drusen load, will start to decrease. If that person's developing atrophy, that is not a good thing. Now, why I bring this up is that her macular pathology impacts her glaucomatous management and functional damage. She's got significant glaucomatous optic neuropathy, but what's the role of her macular pathology? Is her visual field overall fairly stable? I'll say fairly stable, in the right more than the left. But if we really look at, in her case, now this is the retinal nerve fiber layer and the ganglion cell data over time, she has overall a fairly stable retinal nerve fiber layer in the right and left eye. This is flagging just potential areas for change, but significant macular change over time. Why is the GCIPL changing? This is because of her AMD change. So think about the impact of your patient's confounding ophthalmic conditions on your ability to manage and monitor for change their optic neuropathy. Now, a couple of pieces just in wrapping up. This is something that you may have heard about. This is recent. There is now an AREDS 3. So what's the difference between AREDS 2 and AREDS 3, and what are we doing about it? AREDS 3 incorporates B vitamins. We do not have large clinical studies to support the clinical impact of this AREDS 2 on AMD progression, not like the original AREDS 2 based studies. There is data related to B vitamins with, and this is in vitro, so again, in vitro data, not clinical data, AREDS 2 plus B vitamins. In this particular study, it was B5, B6, and folate. Here's the label for AREDS 3. Here's what I see. As less of a statement of exactly what's in it or what the clinical benefit is. What I see is this shift to becoming more holistic, this shift to being more not just about the macular pigment, but thinking about overall systemic health and the impact of micronutrients on retinal and optic nerve health as a whole. I see this as a big step forward for, our medical community overall, not just in allopathic medicine, but really in holistic medicine, and understanding and keeping in mind that we should not be surprised when in the future we see other supplements with an indication or with insight that it may improve or may have a positive impact on retinal or optic nerve function. I'm not just talking again about AREDS, I'm talking about nutraceuticals in general. Think about curcumin, think about quercetin, other molecules that have these anti-inflammatory properties. So I see this as a step forward for allopathic medicine to be thinking a little less allopathic through the incorporation of multiple B vitamins in addition to the current AREDS 2 supplement. All right. So I think we've hit home in a number of directions today. And, I've really tried to think about this the way that we take care of patients clinically, which is comprehensively. Even in a specialty environment, when the vision's reduced, we've got to figure out why. When there's retinal pathology, we need to make sure as that patient's quarterback, as their primary care provider for the eye, that patient does have retinal care. When there's an old retinal vascular occlusion, what are the systemic risks? Even though this patient doesn't need treatment today, what does this patient need to have evaluated? Does this person, let's be even more simple, does this person have a primary care provider? Do they have access to a primary care physician? This prioritization, I shared one real case here that really laid it out quite simply. Many cases are not that simple. What's the biggest reason is that patient says, but what about my glasses? Can't I just have the new glasses? I really need new contact lenses today too. This is really our stretch, our challenge, our understanding. Be curious. When you see something that isn't quite right, that can be just a weird defect on a ganglion cell interplexiform layer scan. What's the macular reason that there's that little defect? Is it segmentation error? Or is there underlying macular pathology, whether it needs to be treated or not? You're evaluating that patient, evaluate them completely. And really taking this widespread approach to medical optometric care. working with multiple subspecialists is honestly very rewarding and truly very important work for your patient. So, email address, cell phone numbers here, any cases that come up that you'd love to chat about, I am more than happy to chat. Thank you very much.
Awesome. Thank you so much. What a wonderful presentation. And it's just so nice to see a presentation that's not only focused on something like glaucoma, but all of the comorbid conditions that so many of our patients have that come in and see us. Can you tell us a little bit about if you're managing a glaucoma patient and
Sorry,
they have
sound just cut out for you there, Dr. Sorenzi.
Let's see, can you hear me a little bit better now?
For me, at least.
Okay, I'm sorry about that. Say that you're managing a patient that has a glaucoma patient that gets refractive surgery, like LASIK. Does that change? How does that change your care when you're looking at them from a pressure standpoint?
Sorry, Dr. Sorenzi, I can't hear you, but I do see the questions that are here. I'd love to address them. I'm sorry to interrupt you. You can hear me? Thumbs up? Okay, thank you. So a couple of questions that came in, happy to chat about them. Recently noticed that perimacular change in the OCT scan. Is this the ellipsoid zone in the en-face analysis? So en-face analysis, remember, is anterior through to posterior. That's a little bit more tricky. If you're thinking about full thickness analysis, sometimes you can find that full thickness analysis. Realistically, where the damage should start is at the level of the ellipsoid zone. Once there's RPE damage in hydroxychloroquine toxicity, that really is the point of no return. RPE damage is permanent. That's what we worry about. That's what we try to prevent. Is that toxicity? If you're seeing early ellipsoid zone, inner segment, outer segment junction disruption or shagginess, that very well be early toxicity. What my suggestion would be there is look at your fundus autofluorescence, and absolutely in that case, look at your visual field. And that might be a person, if you're kind of on the fence or borderline, maybe watching carefully for change, or getting ERG on that patient could also be helpful.
Awesome. Is my audio a little bit better now?
Fabulous.
Okay, very good. Another question is, if you have a patient that decides to get refractive surgery, a glaucoma patient that you're managing, how does that change your monitoring process when you're looking at their IOPs?
Great question. So great news is it really doesn't change much, in the sense that if the cornea is now going to be 50 microns thinner, understanding that that person is not at an increased risk of developing glaucoma because they had keratorefractive surgery. Now, yes, the cornea is thinner, which means if the patient has an intraocular pressure of 24 millimeters mercury with a 470 micron cornea, again, that you're underestimating the true thickness. But for someone with a statistically normal intraocular pressure, again, we don't adjust IOPs. LASIK, PRK, SMILE does not increase their risk of glaucoma.
Wonderful. Well, thank you so much for this wonderful presentation. It was so insightful, and we're having lots of good feedback from attendees. Thank you.
Thank you. Have a great rest of your Sunday, everyone. Thanks for joining.
All right, guys, here is our QR code. You can go ahead and open your OE Tracker app, get that QR code instantly. For the last QR code, we will be sending out a survey to everyone. If you missed that, if you just fill out that survey, then we will give you the instructions on how to get that credit for the first 2 hours with Dr. Ibuk. So I'm going to announce our raffle winner for the $50 Amazon gift card, and the lucky winner is Dr. Carla West. So we will be sending that gift card over to you soon, Dr. West. So congratulations. All right, we're going to leave this up a little bit longer. I hope everyone has a wonderful rest of your weekend, and thank you for joining us today.